Academy of Higher Education and Research, Belagavi, Karnataka. And sir has many publications, and he's EC member of All India RSSDI National 2019-22, recipient of Lifetime Achievement Award 2018 from RSSDI Rajasthan chapter. He is a MRCP UK PACE examiner, international advisor, Royal College of Physicians of Edinburgh of North and Central India 2019 to 2024, fellow of American College of Endocrinology, a fellow of all four Royal College of Physicians, and fellow of American College of Physicians, honorary GAPIO Distinguished Fellow, a Vice President American College of Physicians and India Chapter, Chairman elect of RSSDI Delhi Chapter 2022-23, Founder and Secretary of General Innovative Physician Forum. We are very proud to have sir you on the as a first speaker of second day. Over to you, sir.
Thank you very much, Chairperson sir. Good morning to all. Extremely thankful to RSSDI Gujarat chapter, a very vibrant chapter which we are observing and experiencing for last full one day. Good hospitality, good programs, very good scientific program. The topic assigned to me today is the autonomic neuropathy, and since it is a diabetes conference and it is being done under the banner of RSSDI Gujarat chapter, I would focus on autonomic neuropathy and diabetes. My special thanks to Dr. Pratap and Dr. Bansi Sabu. This will be the plan of presentation. Now, we all have seen this diagram in our old age books of physiology, of anatomy, but I will not take you in detail about this. The reason for presenting it here is that it is a complex system. It is not that easy as we think of, that it is of a sympathetic nervous system, the parasympathetic nervous system, and you can see from the top to bottom that every part of the body is being governed by these autonomic nervous system. The sympathetic nervous system, it activates the body through the thoracolumbar, and they are short preganglionic and long postganglionic fibers, and they have a global response. Postganglionic transmitters, except sweat glands, they are governed by the acetylcholine. The parasympathetic nervous system, it prepares the body for the rest and for digestion. Craniosacral, starting from the cranial nerve up to the sacral nerves, long preganglionic and short postganglionic fibers. That is the difference in the anatomy of this sympathetic and parasympathetic nervous system. It is discrete and has local responses, and postganglionic transmitters is through the acetylcholine. Now, when there is a state of fight and flight, it comes through the sympathetic nervous system through activation, increased heart rate, which increases sweating, dilates the pupil, inhibits gastrointestinal movements, closes the sphincters, diverts the blood from skin and GI tract to the skeletal muscles, and this we must have observed in ourselves also at a number of times. On the other side, the parasympathetic nervous system is the rest and digest system. It promotes the digestion and the GI peristalsis. It slows the heart rate, it constricts the pupil, empties the bladder, relaxes the sphincters, mediates genital erection. So they go opposite to each other. Now, when we talk of the diabetic autonomic neuropathy, 25 to 50% of these people, they die within 5 to 10 years of diagnosis, and that is the importance here. 5 years mortality rate is 3 to 5 times higher, and the marker of adverse cardiovascular, renal and cerebrovascular outcomes, and varying reported from 5 to 35%, symptomatic autonomic neuropathy long after the onset of diabetes. So when the person is diagnosed with diabetes, in type 2 diabetic patients, we go for the examination and assessment of diabetic autonomic neuropathy right at the time of diagnosis, and in type 1 patients at 5 years of diagnosis. But the subclinical autonomic dysfunction is very common. Now, it is associated with peripheral neuropathy, so you cannot divide that this patient only has autonomic neuropathy. But parasympathetic dysfunction may appear independently also. Hence, test for sensory and motor nerve functions like the monofilament, quantitative sensory testing, the nerve conduction studies, muscle strength studies may not be effective in detecting the diabetic autonomic neuropathy that cardiovascular autonomic function testing can detect at early stage of emergence. Thus, the test for other forms of diabetic peripheral nerve dysfunction should not substitute for the test for cardiovascular autonomic dysfunction. If you go for the testing of peripheral neuropathy and if they come out to be positive, then we should not leave it like that. Now this patient must be having the cardiovascular autonomic dysfunction also. We must test them separately. The risk factors are, first and foremost, is the poor glycemic control. Long duration of diabetes. As the duration of diabetes increases, the risk factor, this becomes another important risk factor. Increasing age, especially in the female gender, higher body mass index, and to some extent possibly smoking and the elevated triglycerides also, but there is no definitive evidence for this. So why we should talk about this, and why every physician, every healthcare provider who looks up the diabetic patient must know about this particular entity. It is a serious and a common complication of diabetes mellitus. Frequently coexist, as I told you, with the peripheral neuropathy and other diabetic complications. Frequently precedes the detection of other complications, and the prevalence varies depending on whether studies have been carried out in the community like clinic or tertiary referral centers. There are only very few centers or few places where the studies for this diabetic autonomic neuropathy is being carried out. Lack of standard accepted definition of diabetic autonomic neuropathy and different diagnostic methods, and then the 5-year mortality, as I have already told you, showed symptoms of diabetic autonomopathy and disrupted heart rate variation in cardiovascular autonomic function was 53% compared to only 15% in diabetes without autonomic dysfunctions. When we talk about the pathogenesis, very easy pathogenesis, and practically it covers all aspects of diabetic complications through the hyperglycemia, the neurovascular insufficiency. They act through the sorbitol, the AGEs and the PKC, then the autoimmune damage, neurohumoral growth factor, and the EFA deficiency and free radical injury. So disorders of the polyol metabolism, disorders of fatty acid metabolism, accumulation of glycated end products, endoneural ischemia, oxidative stress, destruction of nerve growth factors and axonal transport, immunological, autoimmune, inflammatory, and these are the pathological factors or the mechanism through which all the complications of diabetes they take place through one or the other. Now, what are the systems involved in diabetic autonomic neuropathy? As I have told you, the autonomic nervous system that affects every part of the body. So we expect that every system of the body should be involved. Through the vagus nerve, 75% of all parasympathetic activity, and that is the earliest nerve. Effects are widespread, but symptoms may be related to single system. They can cover the cardiovascular, where there may be resting tachycardia. And one of the dinner talks yesterday, it was being discussed that we all doctors, we are always at a stage of resting tachycardia, whether we are diabetic or not. But those who are diabetic, they have a more evidence of this. Then orthostatic hypotension, which is very common. Exercise intolerance and the silent myocardial ischemia. So in cardiovascular system, we have to look for all these factors. I'll tell you how we go for the cardiac autonomic nervous system assessment. Then the gastrointestinal, esophageal dysmotility, constipation, diarrhea, and the fecal incontinence. Certain patients come to us with diabetic diarrhea, others come with diabetic constipation. Now the genitourinary neurogenic bladder, erectile dysfunction, which is very important, retrograde ejaculation and dyspareunia. In metabolic, there is hypoglycemic unawareness, and this hypoglycemic unawareness at times become very dangerous. Patient of diabetic autonomic neuropathy having hypoglycemic unawareness, at the night time the patient goes into hypoglycemia, and early morning we see that the patient did not wake up, and the reason was that this patient must be having hypoglycemic unawareness. Then hypoglycemia associated autonomic failure also. Then pseudomotor anhidrosis and dry skin, heat intolerance, and decreased diameter of the dark at the dark of the pupil, that is adapted pupil. So this is very important. You must have seen the loss of hair, the shining of the skin at the foot, at the lower limbs of these people. Now, differential diagnosis, pure autonomic failure, There may be, formerly it was called idiopathic orthostatic hypotension, multiple system atrophy with autonomic failure, the Addison's disease and hypopituitarism, hypovolemia, peripheral autonomic neuropathies, and the medications. So these, when we talk of this particular entity, we must always evaluate for these differential diagnosis causes. Now coming to the cardiovascular autonomic neuropathy, the clinical manifestations are impaired heart rate variability and resting tachycardia and the fixed heart rate. Then the blood pressure changes, nocturnal hypertension, orthostatic hypertension, postprandial hypertension, and limited exercise tolerance. And the other clinical implications are QT prolongation, which is very, very significant. And we all must see, in our patient's electrocardiogram, what is the QT type? Altered repolarization, nocturnal arrhythmogenesis, and death. Silent myocardial ischemia is very, very common in diabetic patients. And then comes the diabetic cardiomyopathy. Patient is diabetic, the coronaries are not critically blocked, but still the ejection fraction has come down, and that is the silent myocardial diabetic cardiomyopathy. Intraoperative cardiovascular liability, vasopressor support, and severe inotrope hypothermia. And this is a very particular problem with the, not with the surgeons, with the anesthetist. A diabetic patient, they have to look for this cardiovascular liability intraoperatively, and stroke of course is common. Now how to evaluate? I'll take you through the technique. Heart rate response to deep breathing, heart rate response to standing, and heart rate response to Valsalva. But practically I'll let you know. This is the actual cardiac autonomic neuropathy dysfunction measurement in our patients, which we regularly do. We look for the parasympathetic functions, where we check for the four things: the resting heart rate, the resting tachycardia, then with change in the RR variability with the deep breathing of the patient, and then with the standing and Valsalva maneuver. So through these four, we go for the assessment of parasympathetic function in these patients. And for the sympathetic function, two important: one is the postural hypotension, and the second is the sustained hand grip exercise and the change in blood pressure with that. Now there are many stages of this. The early stage, when there is abnormality of heart rate response during deep breathing alone. The intermediate stage, when there is abnormality of with the Valsalva response, and then the severe stage, the presence of postural hypertension. So we can classify this cardiac autonomic neuropathy into three stages: early, intermediate, and the late. Now, looking at the safety, the high value to risk ratio, some adverse effects like the Valsalva maneuver. There is transient increase in intracranial, intrathoracic, and intra-abdominal pressure, and theoretical possibility of intraocular hemorrhage and lens dislocation. So, it is very important we have to take a good history. Patient has any history of retinal detachment or this retinal hemorrhage, we should avoid this test. If the blood pressure is very, very high, then also we should avoid this. And if the patient has recently gone into any lens surgery or eye surgery, that also, because we all know that with the Valsalva maneuver, the intrathoracic, intracranial, and intra-abdominal pressures, they rise. So any problem giving rise because of this increase in the pressure, we must avoid. And then the children, mentally disabled, and aged patient, where it is difficult to perform and it is difficult to explain them. If the patient is not cooperative, then we should not go for this test. So this test of cardiac autonomic neuropathy, we have to be very, very selective in our patients. But another very simple thing is that first is the postural hypertension. We take the blood pressure of the patient when patient is lying down supine comfortably, then ask him to sit up. And sit up for 2 minutes and look for the postural hypertension. Again, then ask the patient to stand up and again change the blood pressure. And once at least in the examination of the patient, we must check the blood pressure in both the arms. Because if there is a difference of 10 milligram or so in both the arms, then again it signifies that this patient must be having an underlying this problem. Now, there are newer non-invasive tests like power spectrum analysis, MIBG spect, and 11C hydroxyapatite scintigraphy. What is the treatment of impaired heart rate variation? And when there is prolonged QT, acute management is magnesium, temporary pacing, and isoproterenol. And the chronic management is avoid precipitating factors, electrolytes, and the PEM pacing. If there is sudden, we must have seen that there are certain patients where we go for sudden cardiac death, we look that this patient has sudden cardiac death, then of course, if there is any evidence that this will lead to sudden cardiac death, then we must go for the pacing and the ICD. Now, what is the treatment of orthostatic hypotension? There are general measures which are very important, and the first is gravity shoots and the stockings. Changes in the posture to be made slowly in stages. We have to explain to the patient, we have to make the patient educated about this. Tensing the legs, dorsiflexing the feet, or doing hand grip exercise before standing, high salt diet, increasing water consumption, treat anemia, avoid drug aggravating this orthostatic hypotension. In the pharmacological measures are glycemic control and multifactorial risk reduction, alpha lipoic acid and ACE inhibitors, but how much is the role exactly, we cannot say. The other drugs are midodrine, fluorocortisone, that is beta blocker, not clear, clonidine, severe side effects, and desmopressin, but I don't know many of us are using all these. Then octreotide, especially for the postprandial hypertension, to 20 to 2200 microgram per day. Coming to the GI autonomic neuropathy, I'll take 2 more minutes only. The esophageal dysmotility, then gastroparesis, diabeticorum, enteropathy, constipation, fecal incontinence, and gallbladder atonic and the enlargement. And once we know about these, then only it can come to our mind. The clinical presentation is bloating, early satiety and postprandial fullness. Patient कहता है मुझे भूख नहीं लगती, मेरा पेट फूल जाता है. Dyspepsia and brittle diabetes. Clinical evaluation, again, history of the drug. Metabolic evaluation, endoscopy, barium radiography, ultrasonography and MRI. The gastric emptying scintigraphy, low fat, egg white meal, and then you do the imaging with the 2 hours defined delayed gastric emptying. Then this is the treatment of gastroparesis. This is the algorithm: mild, moderate and severe, dietary, nutritional support, then the pharmacological, and then comes the non-pharmacological or non-gastrointestinal. Again, the pathogenesis of diabetic diarrhea remains autonomic dysfunction and associated factors. Autonomic dysfunctions, they cause the altered motility, increased secretion, bacterial overgrowth, anorectal dysfunction, and the exocrine pancreatic. And when we clinically suspect with the history of the patient, then we must go for this specific test, but at least we must take the history of our patient with associated factors like the dietetic foods, concurrent diseases, and look for bile acid malabsorption. Now, this is how we evaluate for diarrhea in patient of diabetes or diabetic diarrhea. Then treatment, again, initial fluid and electrolyte management. Nutritional efficiency should be treated specifically if found loperamide, clonidine, octreotide and fecal incontinence drugs to reduce the stool volume. Now, genitourinary, neurogenic bladder erectile dysfunction, and very important is the female sexual dysfunction where there is decreased libido and vaginal lubrication causing the dyspareunia. We evaluate for the bladder, urine culture, post-voidal residue, renal function test, cystometry and voiding cystomatogram. Erectile dysfunction, again, very important is history, the physical examination, biochemistry, hormone, penile Doppler therapeutic trial with sildenafil, intracavernosal injection of the vasodilators. These are the part of the management. And then reservoir ejaculation, very common. It causes prostatitis, chronic prostatism, azoospermia with spermaturia in postcoital urine specimens. And this is how to evaluate the diabetic patients with erectile dysfunction through the history, physical examination, trial of adjuvants. Treatment, again, bladder and erectile dysfunction. In erectile dysfunction, the treatment 5-PD inhibitors, intracavernosal papaverine and transurethral alprodostil. The other miscellaneous are metabolic, pseudomotor, peripheral vasomotor, the peripheral edema and venous prominence. We all see with our patient. The loss of sympathetic vascular innervation results in high peripheral blood flow through AV shunts and abnormal local reflex vascular contract, increased osteoclastic activity resulting in reduced bone density, proneness to fractures, and that is possibly the pathogenesis of Charcot's neuroarthropathy in our patients. Then pupil involvement, AR pupil, diminished hippus and reduced dark adaptations. Now the guidelines for diagnosis, they were given long back in the year 1988 by San Antonio Conference. The symptoms not to be considered as markers, non-invasive validated autonomic function testing should be done. Abnormality in more than one test on more than one occasion is desirable, and both sympathetic and parasympathetic functions should be tested independently. For the assessment of cardiac autonomic neuropathy, panel recognized 3 tests of heart rate control and 2 tests of blood pressure control. These tests were just suitable for both routine screening and monitoring the progress of autonomic neuropathy. No other tests, including those for GI, genitourinary, pseudomotor, microvascular skin blood flow, and pupillary function, were considered to be sufficiently well standardized for routine clinical use. So, dear all, please look for the diabetic autonomic neuropathy features, the complaints, the history in our patients always, and then only we can assess about this particular and very, very important entity. With that, I thank you all for the patient listening. Thank you, sir.
It was indeed wonderful and insightful talk, sir. There is very high mortality in autonomic dysfunction within 5 to 10 years. Still, it is underdiagnosed and undertreated. So we must have detailed evaluation of our patient for autonomic as well as cardiac autonomic neuropathy. If there is any question from audience, we would like to take it right now.
Yes, sir.
Sensory problems, tingling numbness, we have many of the agents. Which one you prefer? I personally.
Tingling numbness. This comes into the peripheral neuropathy system. So the first and foremost is the 10 gram monofilament. We even do at the bedside. In your OPD clinic also, it hardly takes 1 minute. There is only 2-minute foot examination for such things. First is that put your fingers on the vasculature, on the peripheral arteries of the patients to look for if there is any evidence of peripheral arterial disease, and look for the general sensation of the patient. Take a good history. Treatment line. If there is B12 deficiency, I think there is another topic today of painful diabetic neuropathy. But I tell you in gross, first thing is that if there is any deficiency of vitamin B12, because that also aggravates, we must supplement vitamin B12, we must supplement vitamin D. And then there are 2 drugs which are, these are approved by the FDA. One is the duloxetine and another is the pregabalin. So we can start with pregabalin at night time. Small dose, start with 50 milligram OD, increase it to 50 milligram BD, then increase to 75 milligram OD or BD. The standard dose which is given in the books and approved by FDA is 300 milligram per day. But we don't give out patients improve much faster. But before that, very important is if the blood sugar levels are not under control, if the patient is not in the euglycemic stage, these drugs are not going to help. Thank you very much, sir.
I would invite Dr. Umesh sir to facilitate Sarma sir with memento. So the second speaker is Dr. Amit Gupta from Noida. He will talk on use of social media in diabetic education and management. I would like Dr. Umesh sir to introduce our next speaker.
Good morning. Good morning, everyone. Dr. Amit Gupta is MBBS, DNB, MNMS, FSC, FRSSDI, FICP, FISH, FRCP, FSCP, FIMSA, FGSI, FISEM, Fellow Diabetes India. He is a director of Center for Diabetes Care, Greater Noida, Joint Secretary Diabetes India. He is advisor American Diabetic Associations, Public Health and Epidemiological Group and Membership Advisory Group. He is also Executive Council member of RSSDI National. He is along with ACP India Chapter, Indian Society of Hypertension, and RSSDI UP Chapter, UPDA. He is having Apex Body member, North Apex, The Art of Living Trust from 2019 to 2021. He is executive editor in Sedicott International Textbook of Diabetes, 2nd edition, RSSDI Proceeding 2022. Reviewer of Endocrine Practice, AAC Case Reports, Journal of Clinical Diabetology, Poland. He is also having Diacare Award for leading most successful diabetic campaign, Defeat Diabetes 2021. ACP India Chapter Community Teaching Award 2021. Times of India Health Icon Award 2021. Diabetes Excellent Award 2021. Dear Diabetes Academy. So now I invite Dr. Amit Gupta to start his lecture.
Thank you, sir. Thank you for the very kind introduction. And at the outset, I would like to thank Dr. Umran Dhruv, Dr. Pratap Jethwani, Dr. Bansi Sabu, sir, for inviting me here for this prestigious Diabetica conference of RSSDI Gujarat chapter. So, after a very complex talk of Dr. J.K. Sharma, sir, which we all believe that diabetic autonomic neuropathy is something which we don't usually check regularly in our clinical practice because it involves a lot of complexity and intricacies. So, this is something which is very, very common. All of us are using social media. So, I was given this task to discuss what is the role of social media in diabetes management and education. So, I don't have too much to show in my slides, but I would like to keep it more interactive. So just to move it forward, I would like to ask how many of us are actually on social media? WhatsApp, Twitter, Facebook, LinkedIn, and YouTube. How many of you know that RSSDI has a social media handle on Facebook, Twitter, Instagram, as well as RSSDI has a YouTube channel? So, the purpose of this talk is to highlight that how many of you are aware that a lot of journals like Diabetologia, ADA journals, Lancet, NEJM, the coveted journals in the world, they are using social media to educate doctors. The doctors are using social media to educate patients. So this is a complex thing. So I would be highlighting some of these things. So how many of us are aware that NMC has included a whole set of guidelines for the use of social media also, which is going to be in place from the next month? So my talk is going to focus on all these things only. So let us talk about the journey of social media and RSSDI itself. In 2016, I was first given the task of speaking on role of diabetes management in social media in one of the conferences at Delhi by Dr. Bansi Sabu sir, when he asked me to speak on in the World Congress of Diabetes India on role of social media and diabetes management. At that time, neither the RSSDI nor the Diabetes India, they had any presence in the social media itself. We never had any handle of RSSDI. We never had any handle of Diabetes India also. So what happened then that just after the beginning of the COVID, the Dr. Bansi Sabu, the then president of RSSDI National, decided that RSSDI should be having a social media presence and we should be having a social media task force. So he decided and constructed a task force in which Dr. Pratap Jethwani was also one of the members. Dr. Purvi Chawla, who presented yesterday, was also one of the members, and I was also one of the members of that task force. So that task force, in the leadership of Dr. Bansi Sabu and all the executive council members, they decided that RSSDI should be having a social media presence. So we came up with the social media handles of the RSSDI on Twitter, on the Facebook, as well as the Instagram. And one program was conceived called RSSDI Diabetes Bites. So RSSDI Diabetes Bites is a program in which we talk about various aspects of diabetes education almost every week. And this is happening consistently, and more than 100 episodes have been there, and all these episodes are there on the RSSDI website. So I will just request you that the purpose of this talk is to sensitize us about the social media. So you just visit the RSSDI website, rssdi.in. You will find a public education portal, and you can find almost 100 plus videos in which most of the KOL sitting in this hall have already spoken. I think most of us who are leading the chapters, executive council members, secretaries, they've been part of this program. And this program is now half an hour program, and these videos are very good videos. You can play it even in your patient waiting area, because these are spoken by the key opinion leaders of the India, and you will find each and every topic which you can think of. So the first episode was there with diabetes education, are we doing enough? And this was the Doctor's Day special. I remember on the 1st of July when the first time the RSSDI social media Diabetes Bites was launched. This is the Facebook page of RSSDI. If you are not following this Facebook page, I will request you, it will take just a minute of yours. You can just simply browse RSSDI and you will be able to follow up this page, because this page has regular updation about the RSSDI activities. This is again the RSSDI official page on Twitter, and if you find that this time when the RSSDI research retreat was conducted at Pune, almost every 10 minutes there was a tweet from the RSSDI, and it was explaining about the talk, and there was a link which was given to the doctors also, who can go and visit all this thing. This is again the Instagram page of the RSSDI, and you will find these are the latest pictures from the RSSDI research retreat which are there. So if you follow these handles, you will be able to keep keep yourself updated with the RSSDI activities and the social media handles. And this is the RSSDI channel on the YouTube, where you will find all the videos which are uploaded, which are done by the key opinion leaders and the RSSDI members, and you can actually follow these. So before going into details, I would like to highlight this very, very important point, that now the guidelines have come, which are there in the draft, and there have been this was not earlier there. This was not there in the 2008 Code of Ethics. Now the newer Code of Ethics says that what we need to do when it comes to social media. So the broader principle of medical ethics should guide the use of social media by to the registered medical practitioners. So all of us should be using social media, but very carefully. And there are certain things which are now well defined, so we should be following them. And we need to distinguish between what is telemedicine and what is social media. So telemedicine is not social media. So telemedicine is a totally governed by a separate set of guidelines which are there, and all written and visual communication should be truthful, respectful, and professional. Many a times, just before preparing this presentation, I posted a simple question on the LinkedIn, and I asked what is expected from this talk. What are the limitations or what are the challenges of the social media? And we got few replies. So one of the key reply was that whenever we post on social media, we do not mention the source of the information. All of you will believe that we feel that this information is wrong. This is misinformation. For example, somebody will say that I will cure type 1 diabetes. But how to counter that? How the general public will identify that what you are saying is right and what the other person is saying wrong? Because since we are from the fraternity, we feel that what we are saying is the right, but somebody else may be having some other ground to speak. So for a general public, it is very difficult to identify what is the right source of information. So if in all your social media posts, you are able to quote the source of the information. If suppose you say diabetic neuropathy can lead to this and this, and you put the source, whether it is RSSDI, whether it is IDA, whether it is ADA, then the information becomes truthful. Then the people knows that this information is not coming from so and so doctor, and this is not his personal view. This is something which is very well scientifically validated and established. So that has an impact. So this is something which we all should be doing whenever next time you make a post on diabetes education and you put it on social media. Make sure that you are highlighting the source as you highlight in your presentations and something like that. Also, it is said that we can provide information and announcement on social media. However, the information should be factful and can be verified. The information should not be misleading or deceptive, and nor should it exploit the patient's vulnerability or lack of knowledge. So it should not be threatening. That we should not be simply promoting something which is threatening to the patient. So all these things we need to keep in mind whenever we are going to do a social media post. Also, we should avoid discussing the treatment of patients on public social media or prescribing medicines to the patient on the social media platform. So this is very, very important. Many a times out of enthusiasm, if we get a very good case, very good result, we will simply, this is very common in the surgical fraternity, because the surgeons, they will post the videos, pre-surgery, post-surgery, weight loss. So this is now governed. If a patient approaches doctors through public social media, the doctor should guide the patient towards a telemedicine consultation, and you should not do the consultation on the social media platform. So avoid doing consultation on the WhatsApp. Rather than you do it on your telemedicine portal, which whatever the EMR you are using, it should be having an integration of the telemedicine consultation. Also, we should not post the photographs or scan images, even the images of the CT scan or the PET scans on the social media, because many a times we do avoid the photographs of the patient, but we don't hesitate in posting their report. So it is again, this is something which can be an offense in the eyes of National Medical Council. And once an image is posted in social media, it becomes data that is owned by the social media company or the general public. So we need to, the data of the patient belongs to the patient. It does not belong to us. So whenever we are posting any data related to the patient, we should be very careful. It should always be anonymous, and the patient related data has to be posted very carefully, and it should not be directly posted, including photographs and the images of the scan. Also, many a times we have an offensive behavior. Sometimes we don't like a colleague, whatever they are saying. So we will indulge in some counter allegation or the allegation. This is not right. This is not wrong. So we should be very same guidelines as we follow the ethical guidelines. So the social media guidelines again says that we should be having a professional behavior on social media, and we should not be abusive to our own fellow colleagues or the fellow members of our fraternity, and it should be done in a professional way. Whatever the point or counterpoint is there, it should not be something which is arrogant. It should not be something which is disrespectful to the other person in the community. Also, we should not involve ourselves in practices like purchasing the followers or the likes. This is something which you all know, the platforms like Practo, they were doing. They were also taking commission from the doctors to give them the patient, and they were receiving a part of the consultation fee. So now all this is banned. So like and followers, you cannot get like and followers by paying money, and you cannot put something which is already there as a advertisement. And we should also not request or share patient testimonials or recommendation or endorsement or reviews in social media. So this is again which is very, very important. All of us are very fond of getting likes or reviews from our patients because that builds up your profile, that adds. So NMC believes that if we are asking our patients to write recommendation or reviews, then it is something which should not be done. Also, we should not be putting any images of the healed or cured patients or surgery procedure videos, as already discussed. Also, whatever communication, it should be limited to the expertise of our own expertise. We should not be talking about something which, if a diabetologist may not be talking about the ENT surgery or may not be talking about something else. So, if you are not from the internal medicine, you are not from gynecology, you may be avoiding some post on which is not your specialty. So we should be very specific on our specialty, and web page should also follow your own guidelines. We are allowed to create our website, but again the web page should also be following all these principles. On social media, we should also refrain from crossing boundaries or violations and conduct themselves with dignity and decorum. This is very, very important. And soliciting of any patient directly or indirectly, again, through social media is unethical. This is slide. This was the part which I wanted to cover from the NMC. Now, the few slides where I would like to show you that what other organizations are doing. This is from the CDC, that is the Center for Disease Control, US, and they say that social media is an essential part of the public health conversation. And NMC also encourages that we should fulfill our responsibility when it comes to patient education. We should not shy away from it, but it has to be defined by certain guidelines. Why? Because it allows us to reach more and more people who will benefit from the science-based information about preventing and the managing diabetes. So this is very, very important. So what are the challenges with social media? One of the biggest challenges with the social media is that you don't know what is going to become viral. We don't know which kind of information will be taken by the patients or their caregivers in a more positive way. So we should always be very careful, and whenever we need to counter scientifically. Nothing is going to change if we start abusing them, start blasting them on social media that this is wrong, this is wrong. We need to provide the right information, and I think it should come from all of us. When we all write and scientifically say that this information given by so and so person is wrong, and we put the adequate reason that why this is wrong, what the science says, I think our point will be valid and taken care of. Also, the discussion in the online community shows that sometimes newer therapies, some alternative medicine therapies. So all these are promoted on social media. For a lay person, they are all alike. They don't know what is RSSDA, they don't know what is IDF, they don't know what is somebody's else organization which is not having any scientific backup. So we need to promote our own organizations which are having scientific backup. Let's come to diabetes education for the doctors. So doctors, we are also now looking up to medical platforms where we can actually go and look into the visuals and find out what exactly is happening. So this is one of the new platform, that DocTube, which is having all the videos from the RSSDI, from the Diabetes India, and you can go and watch these videos as per your convenience. So this is something which is there, and this is developed in OTT platform. Our organizer RX TV, the RX event is also going to come up with something like RX TV, which is going to be a very good, useful platform for the doctors, where they will be able to say that. When I say that social media, so this is the ADA, which we think is one of the most reputed organization of the world. This is the latest post by the ADA president on the social media, and they ask each and everyone to follow ADA on all these social media handles. You can see there is Twitter, Facebook, Instagram, LinkedIn. So all these handles are there. So please do follow our RSSDI handles also. And these important organization handles are very, very important because they will keep you updated what is happening. This is IDF. IDF is umbrella body of more than 180 organizations all across the world, you know. And this is one of the most important handles which you can follow because it will keep you updated about the latest. And there are blogs which they talk about, which you will be able to actively engage yourself. And this IDF LinkedIn social media handle is very, very good. This is ADA, and this is, you can see the ADA has 144.2 thousand followers, 2K followers. So many followers are there already, and these are all medical professionals as well as many other people who are there. This is one of the recent posts by our own Dr. Bansi Sahu sir, and he highlighted that what is the difference between, so sometimes these motivational posts also come from your own people you like, you follow, and you learn a lot of things from them. Dr. Vijay Vishwanathan was presenting here yesterday. So this is all how we are going to take the education in the social media forward. One more thing which I wanted to highlight, the conclusion slide. So we all know that diabetes self-care is very, very important. So we need to provide trusted information to our patients. It can be given through the social media. Social media has the power to reach many people in a short span of time. Also, you can engage multiple organizations for the help of the people living with diabetes. It is a valuable resource for people with diabetes, as social networks, blogs, and patient self-help sites allow them to contribute to content, share experiences, and make contact with other people in a similar situation. Also, there is also a place for healthcare professionals within these communities, and they can learn a lot about these people with diabetes by engaging with these online resources. You will ask that why I have not shown any study, why I have not shown any slides. If you go and search the role of diabetes, role of social media in diabetes management and education, you will find more than 10,000 researches which are already there. People are writing on the use of WhatsApp, social, Facebook, Twitter, anything. So there is no dearth of evidence. You can simply, these major organizations, they don't follow anything which is not unscientific. So the presence of IDF, ADA, our own RSSDI, Diabetes India in the social media is good enough to believe that social media can make an impact on the people living with diabetes, and also it can enhance our knowledge and skills. When we are not attending the CMEs, we can still benefit by following these handles. Thank you very much.
It is indeed wonderful talk, Dr. Amit sir. And yes, in the era of social media marketing and campaigning, we must know what are the newer laws so that we can put it very properly. Thank you so much for making all us digitonians and enlightening our knowledge on technology and diabetes by DTechCon. I must say that when COVID and lockdown was started, and at that time it was our first conference, that was the Diabetica, which was conducted virtually, and we are having it physically right now. So must congratulate Dr. Bansi sir and whole team. With that, if there is any question from audience, we would like to take it.
Yeah, I mean, there is a misconception in everybody's mind that if you have taken the patient's written consent, you can publish it on social media, which is a myth where you can throw some light.
You are right, sir. The consent is not for social media, and patient data belongs to patient data. The patient may claim next day that there was no consent, and you can be in trouble. So it is better to avoid using the patient's own photographs, their scans, their images. Better to write some case report which you can publish in journal if you think the case is too good to be discussed, or you can use it some anonymous names. You can change the name, you can change the photograph, and you can highlight all the identities which are there on the images. Then something which cannot identify the patient, you can put it, but directly with straight using the images which are there with the names and all is strictly not allowed, sir.
So one important thing is even a WhatsApp group is a social media.
Yes.
Where even your hospital WhatsApp group is a social media where you should not publish with the patient's name. The reason he has already mentioned in it, because once you publish it on WhatsApp or Facebook, it becomes the property of Facebook or WhatsApp, and they can use it anywhere. And that's why you should not use it on a group.
Yes, sir.
Now I
And
request.
WhatsApp communication, sir, keep it minimum. Write only whatever is required.
I request Vipul to hand over the memento to Dr. Amit Gupta. Now I request for the next lecture Dr. Rakesh Parikh, Waist Circumferences and Cardiometabolic Health. Dr. Rakesh Parikh is a fellow of American College of Endo, Royal College of Physicians and Surgeons, College of Physicians and Surgeons of Bombay RSSDI. He is the treasurer RSSDI Rajasthan State Chapter, on editorial and reviewer board of various journals, over 50 publications including textbook of chapters, principal investigator on several global phase 3 trials. Now I request Dr. Rakesh Gupta to start his lecture.
Thank you, Chairpersons, for the introduction, and thank you, Dr. Pratap Jethwani and the whole organizing committee for inviting me to Diabetica. I'll straight away start my topic with the first slide, which is about adipose tissue. So adipose tissue is just not just the storage of fat that we have, but it is now recognized as the largest endocrine organ of the body, because it releases so many different hormones like adiponectin, resistin, leptin, and also the cytokines, TNF, interleukins, etc. Now, adipose tissue is not the same everywhere. As you would know that in children there is more of brown fat in their body, which is metabolically active and which keeps the children active throughout the day. As the age grows, then get converted to white fat. So in adults like us, the majority of fat is white fat, and we have hardly any red fat in our body. And there is something in between that is called as beach fat. So it has got the features of white fat as well as red fat. Now it is known that recently there are people who are studying certain ways by which we can cause browning of fat. So an adult person who has got white fat in his body, people are trying to find out some pathways by which we can convert that white fat into beach fat or red fat, and probably that will be more metabolically active, and that may help us in reversing the metabolic conditions. Also, the regional distribution of fat is very important. The fat which is in the visceral compartment is more harmful compared to the peripheral fat which is in subcutaneous tissue. The visceral fat has more the larger adipocytes are there. It also releases more of inflammatory markers, and it reduces the insulin sensitivity, causes insulin resistance. Which is reverse if you talk about the subcutaneous fat in the peripheral tissue. Now, why so? Because the blood from the peripheral tissue, it goes in the circulation in the heart and the brain and the muscles, but the blood from the visceral compartment, it first goes to liver. So liver is exposed to the metabolites of that adipocytes, and that is what leads to inflammation in the liver, fatty liver, and insulin resistance. Now this visceral fat has a strong correlation with different components of metabolic syndrome like insulin resistance. So in this slide, as you can see, on the x-axis there is the volume of adipose tissue in the body, and on the y-axis is the glucose disposal rate. So as is seen from the slide, as the visceral compartment fat tissue volume goes up, the insulin resistance increases and the sensitivity goes down. Now this is an interesting slide about the dyslipidemia that we see, the classical dyslipidemia that we see in our diabetic patients. How does that happen? So insulin has an action of inhibiting the lipolysis from the adipose cells, but because of insulin resistance, this action is not happening properly, and that is why there is large amount of free fatty acids which are released from the adipose tissues in the visceral compartment because of lipolysis. And because of that, the blood goes to the liver, and liver is exposed to large amount of free fatty acids, then which are then converted to triglycerides and glycerol. Now the liver becomes rich in triglycerides, and that leads to fatty liver, which we commonly see in our patients who are obese and pre-diabetic. Because the liver has got large amount of triglycerides, the VLDL which is released from the liver is rich in triglycerides, and because it is rich in triglycerides, it exchanges the triglycerides with the HDL, with the cholesterol ester transferase protein, and this causes the HDL to become rich in triglycerides, and that is how the HDL particles become smaller, and then they are metabolized in the kidney. So HDL to the larger HDLs are good for our body, but if the size goes down, then they are not having those beneficial effects. Similarly, it also exchanges the triglycerides with the LDL, and the LDL also becomes rich in triglycerides, and because of high amounts of triglycerides, these LDL particles become dense, small and dense, and that is what the classical atherogenic lipid profile that we see in these patients. So these patients who are having central obesity, they are classically having high amounts of triglycerides, low amounts of HDL, and high amounts of small dense LDL particles, which are all atherogenic. Now, in addition to insulin resistance and dyslipidemia, it also leads to hypertension in long term because of there is sympathetic overactivation because of inflammation, and there is vasoconstriction. The cardiac output goes up, sodium reabsorption increases, and the patient becomes hypertensive. Because of hyperinsulinemia and hyperglycemia, the patients in turn land up to hypertension and type 2 diabetes. Now, with all these different mechanisms, ultimately what happens is that patient develops the endothelial dysfunction, there is atherosclerosis, and the patient lands up into either CAD or congestive heart failure. So this is the whole chain of events which all start from the central obesity, which is the key conspirator and leads to all these different metabolic abnormalities like insulin resistance leading to diabetes, hypertension, endothelial dysfunction leading to atherosclerosis in future, and dyslipidemia contributing to it. And that is why this entity is recognized as metabolic syndrome, which is the constellation of these different easily identifiable factors like central obesity, which is measured by waist circumference, which is the easy clinical parameter to measure the central obesity, impaired fasting glucose, high blood pressure, high triglycerides, and low HDL. Now, does it have any clinical significance? So this is a study, COPIO heart study, in which they have looked at the all-cause mortality and cardiovascular disease mortality in patients who are having metabolic syndrome and not having metabolic syndrome. So as you can see from the graph, the patients who have metabolic syndrome, they have a relative risk of 2.13 times compared to those who do not have of all-cause mortality. And when you talk about only cardiovascular disease mortality, it is 3.55 times in patients who are having metabolic syndrome. Not just metabolic syndrome, but the components of metabolic syndrome, how many components the patient has also matters. So as you can see here, the last one is for the people who do not have any component of metabolic syndrome, or the people who are having one component of metabolic syndrome, like only central obesity or only hypertension or only impaired fasting glucose. Patients who are having 2, 3, 4 or 5 parameters. So as the number of components of metabolic syndrome in a patient goes up, the risk of CHD death and non-fatal MI goes high, as well as the risk of new onset diabetes increases very significantly as the more and more number of components are added. Again, the same thing is shown in the slide. As the number of components of metabolic syndrome goes up, the risk of developing diabetes as well as cardiovascular disease goes high. So metabolic syndrome definitely has got very much significant role, and if we can identify these people at an early stage, we can probably act early and prevent these complications. But the problem is that the definitions of metabolic syndrome have been changing over the last few years. This was an article which I wrote along with Dr. Mohan on different definitions of metabolic syndrome. And this was the definition that came up very early and was recommended by ADA, which is NSAID ATP3 definition for metabolic syndrome. Now, in this definition, they defined metabolic syndrome as presence of 2 or more of these 5 parameters. The first one being abdominal obesity, defined as the waist size of more than 102 centimeters for males and more than 88 centimeters for female. Then HDL cholesterol for men less than 40, for female less than 50, triglycerides, high fasting and high blood pressure. And if somebody has got any 3 parameters, 3 or 4 or 5, then he becomes metabolic syndrome. Now, the problem with this definition is that these cutoffs which were suggested by ADA are actually very high for our Indian population. You don't see many people with waist size of more than 40 inches in India, and that is why we will miss out on many patients who are actually having metabolic syndrome, but they are not captured because of this definition. And that is why there were so many papers, especially from Dr. Anup Misra's group at that time, and then different papers from different countries like China, Japan, and they all suggested their own cutoffs. So for India, the cutoffs were suggested as more than 90 for males and more than 80 for females in centimeters. Another problem with this definition is that, see, if you have a patient who is type 1 diabetic or a patient who is uncontrolled diabetes, now because he is uncontrolled diabetes, even if he is lean and thin, doesn't have central obesity, may not have the components of metabolic syndrome, but because of high blood sugars, we know that the HDL goes down, the TG goes up, and he qualifies to be a candidate of metabolic syndrome, although he is not, because the basic pathophysiology there is insulin deficiency and not insulin resistance. So this definition was misdiagnosing those people as metabolic syndrome, and so then came the IDF definition, which is the International Diabetes Federation global definition for metabolic syndrome. Now, in this first change that they did, it was central obesity was identified as the component that is required to qualify somebody as having metabolic syndrome. In addition to central obesity, you should have 2 of the remaining 4 parameters. Now, to define central obesity, they again had different cutoffs for different genders, for the males and females, and for different races, and they left it open for the other countries which are not included here, that they can have their own local data and have their own cutoffs. Now, the simple issue of metabolic syndrome, which is supposed to be very simple to identify people at risk, has become complex. Now, it is very difficult to mug up the whole definition of IDF metabolic syndrome criteria. The major problem is of having different cutoffs for males and females and for different countries. Now, do we actually need these different cutoffs? So we did a study in 2007, and we compared the average heights of different countries, average heights of males and females, and then we applied the waist circumference cutoffs which are suggested by the IDF division for the same males and females of that country. And what we observed is that if you just take the ratio of waist circumference and height, you might not need different cutoffs, because the ratio boils down to something around 0.5. So you are requiring higher cutoffs in USA or Europe because the people are taller there. You require lower cutoffs because the people are shorter here. Females are shorter than males, and that's why you need a lower cutoff. So rather than taking waist circumference only as a cutoff, you can probably have a different index, which will be the ratio of waist circumference and height, and that is where we proposed a parameter, that is index of central obesity, which was defined as ratio of waist circumference and height. And to confirm whether it has actually gender neutrality, means can you apply the same cutoff for males and females, we did this study in KEM, and in this study we had males and females, and we picked up the people with a waist size of more than 94 males and more than 84 females as defined by the IDF. But when we look at their ICO, which is ratio of waist circumference and height, the lower range was 0.51. So which means that you can have a common cutoff for both males and females of the same country. Then this was the hypothesis which are published, that probably index of central obesity would be a better parameter of identifying central obesity. And we also propose that maybe we can replace waist circumference by ICO in defining metabolic syndrome. Again, Dr. Mohan and Dr. Shashank were the co-authors in this paper. So this was the simple definition of metabolic syndrome that we proposed. Somebody having index of central obesity of more than 0.5 means somebody having the waist size which is more than half of his height or her height, plus any 2 of the other 4 parameters, can be labeled as metabolic syndrome. Then we also had to verify whether the definition works. So we did a study in which we compared the IDF definition and our modified definition in identifying people at metabolic syndrome. So for doing a study like this, you need to have some gold standard. So that time the AD definition was the gold standard. So gold standard was AD definition, and then we compared the sensitivity and specificity of these 2 different definitions. And this is the result of that study. So when you modify the definition, your sensitivity goes up, but the specificity goes down. And same for males and females both. So if you can replace the waist circumference by ICO, you will not require different cutoffs for males, females, and different genders, but you will probably have a less specific definition. Now, why is it so? Because metabolic syndrome is actually a screening tool. So you don't want to be very specific. You can, there is no harm in labeling somebody as having metabolic syndrome if he doesn't have. So sensitivity is the major important issue, because you need to capture more and more people who are at risk. Secondly, in this study, we have used NSEP-ATB3 as the gold standard, which itself has got limitations. Thirdly, the people who were found to be false positives in our study were probably because they were short. They were shorter than the whole cohort, and to verify that, we again did the study, and we found out that in reality, the whole cohort, if you compare their heights with the people who are found to be false positives, there was a significant difference. So which means that if you have a very short person of 4 feet, his waist size might be only 88, so it doesn't qualify to be central obese as per any definitions, but for his own height, that is also high, and that was picked up by using ICU. So in this study, the conclusions were that by modifying the ID definition with ICU, we can have a better sensitivity with compromised specificity, and it has a potential to be used with a common cutoff for both males and females and across races. Also, it can be applied in children, because in children, again, you are counting the height as well. So this reduced specificity of modified IDF definition might be because of inability of the gold standard to pick up the short people, which were picked up by use of ICU. And then we published this paper again along with Dr. Shashank. Index of central obesity is better than waist size in defining metabolic syndrome. This was a study. And this is a very simple message that you can give to the community with the use of this novel parameter, index of central obesity. Even to normal people, you can say them that you should minimize or you should keep your waist size to less than half of your height. So most of us know our waist size. People know that I'm 38 or 36 or 39. We also know our height in inches. So if your waist size is more than half of your height, you are at risk of metabolic syndrome, and you should screen yourself with fasting sugar and blood pressure and lipids. My last two slides to summarize. So visceral adipose tissue is bad because the blood from this visceral compartment goes to liver directly, and because of that the liver is exposed to free fatty acids and cytokines, which lead to inflammation and fatty liver and insulin resistance. Because of that, because of the insulin resistance, the patient develops hyperinsulinemia, and you might pick up the patients at this stage when they are having impaired fasting glucose. Later on, they might progress to diabetes, which leads to complications like CAD. Also, because of this, as I showed earlier, it leads to the classical dyslipidemia pattern, which is atherogenic, which again leads to atherosclerosis and might land up in CV complications. Again, another important aspect which is not often talked about is because of this hyperinsulinemia and because of insulin resistance, people are developing, the females are developing PCOD. This topic was covered yesterday by Dr. Sunil Jain in his presentation, and Dr. Bansi always talks about this, that because of this PCOD, we are having GDM. And because of GDM, the babies, the in utero environment is such that the babies are programmed to develop insulin resistance in future, and that is what leads to genetically programmed baby who are at risk of getting obesity and diabetes in future. And that is why you are seeing that this vicious cycle has set in. You are having females who are resistant, they are not diagnosed properly, they are not treated properly, they develop a baby which is IUGR probably or small for birth and then small for weight, and then develops insulin resistance and obesity in future life. And gradually we are seeing more and more people who are centrally obese, and this was again a paper on that the human architecture is actually changing. Now we can recognize that most of us are having that adiposity, central adiposity, and the tummy is there. So I would just stop myself here with the message that we should highlight the importance of central obesity and tell all our patients to keep their waist size to less than half of their height, so that they can prevent the future development of complications. Thank you, Chairpersons. Thank you.
It is indeed wonderful as well as informative talk, and we can see so many work you have done in obesity and metabolic syndrome. Yes, waist circumference is a marker for obesity as well as a cardiometabolic risk factor. Under guidance of Sanjeev Phatak sir, we recently have a study for waist to height ratio with Bhavik, and we are about to also publish that thing. If there is any question from audience, we would like to take it.
So this WHR was used earlier because earlier it was identified that the gluteal fat is good, and so if you compare waist size with the gluteal fat, that hip ratio, that can be a parameter, but then it did not work out well. Earlier studies showed that WHR is a good parameter, but later it was found that there are people who are having very high abdominal obesity as well as gluteal obesity. The ratio becomes normal. So that is not in practice nowadays. Yes, sir.
Suggest that the shoulder should also be kept under we have to thought about it, because sometimes the build is very short, moderate, or like more hefty build. If shoulder is good, the shirt size is 42, then that should be considered.
Yeah, so see, there are different studies. People have looked at various things. There was a lot of work done by Dr. Anup Mishra's group on skin fold thickness also. They have used vernier caliper to measure the skin fold thickness. Different cutoffs were suggested just to look at skin fold thickness in different regions, the posterior region, the anterior region. Some people have also looked at the chest size. chest circumference. Basically, you need to keep it very simple so that the people can do it easily, and it can be applied in masses for scaling it up. And when you propose some parameter, then it has to be proven with these studies. So if somebody does a study looking at the shoulder size and its impact on the cardiovascular events or risk, then probably it can come up in future.
So if there is no more question, thank you, Rakesh sir.
Thank you.
I
Thank
would
you.
like Umesh sir to present memento to Dr. Rakesh Parikh sir. With this, I close the session 4 for Hall A, and I would invite Dr. M.G. Patel sir from Gandhidham to chair the session with Dr. Umesh Goidia sir for Novo Symposium.
Sanjeev to present the memento. I think so could have his own one more memento.
Good morning to all. Welcome for Novo Symposium. I invite Dr. Sanjeev Phatak from Ahmedabad to start his the first talk on update in hospital hyperglycemia management. Hardly he required any introduction to this audience because he is known all over the Gujarat, not only in Gujarat but in the western part of the country. Over to Dr. Sanjeev.
Good morning and thank you very much RSSDI organizers, Dr. Bansi, Dr. Jetwani, Dr. Urban Bhai, Sandeep Bhai and the whole team of RSSDI, and thank you chairpersons for the kind introduction. This is a Novo Nordisk symposium, so the talks which are there in this symposium are obviously sponsored talks, but the views which we will be presenting will be our own views. Well, I will be talking about the updates in the hospital, hyperglycemia with the ultra long acting basal insulin, that is Deglued. The financial disclosure I already mentioned. We'll be talking about the management. Do we have a pointer here? Oh, mouse. Okay, fine. We'll be talking about management of hyperglycemia in the hospitalized patient and why basal bolus regime should be preferred, and amongst the basal bolus, what advantage the new basal insulin, that is Deglued, can offer. We'll be discussing in next 15-20 minutes. We know that hyperglycemia is associated with increase in hospital mortality, and it is not the hyperglycemia in the diabetic people itself. Also the new onset hyperglycemia, you can see from this slide that patients with normoglycemia are having lowest mortality and in hospital stay. Patients with non-diabetes, and especially patients with non-diabetes with hyperglycemia, have longer hospital stay and more mortality also. But very importantly, the newly discovered hyperglycemia or the new onset hyperglycemia, which is detected for the first time during the hospitalization, carries the highest mortality. And COVID was the time when we really realized that the new onset hyperglycemia actually had more complications, more COVID related deaths, more hyperglycemia related complications, as well as probably mucormycosis, which was never seen in those diabetic patients, was seen when they were exposed to severe hyperglycemic states. We know the association between the glycemic variability and its relation to the length of the hospital stay and mortality also. for every 10 milligram increase in the standard deviation, the length of hospitalization increases by about 4 to 5%. And for every 10% increase in the standard deviation, which is the standard measure for the glycemic variability, the relative risk of death up to 90 days is also increased by 8%. And this is independently associated with the mortality as well as the length of hospital stay. So the glycemic variability, not just the hyperglycemia, but the variability is also very, very important. And that is why in the hospital we should be using the agents which has less variability. The careful management of inpatients is always required, especially regarding the hyperglycemia and hypoglycemia. Both are concerned. So addressing both this with the agents which has good efficacy as well as less risk of hypoglycemia are obviously welcome at this stage in the hospitalized patients. What are our aims of treating a diabetic patient when he is in the hospital? First and foremost is to restore stable and maintain also stable glycemia, to minimize the disruption of the metabolic state, to minimize the adverse outcomes including hypoglycemia, to shorten the hospital stay, to reduce the readmission rate because of hyperglycemia, hypoglycemia as well as due to other complications, and to improve the patient outcomes overall. How do we manage a patient who is hospitalized for maybe some other reason? How do we manage his glycemia? The anti-hyperglycemic therapy, usually the oral antidiabetics are discontinued in the hospital, except in few cases where you can continue with very small dose of metformin or an AGI if patient is taking orally. But in all other cases, we generally discontinue the oral agents. GLP-1s may be an exception, but patient who is hospitalized for some severe illness, you need to cut down on all the oral agents. So insulin remains still the therapy of choice for all the hospitalized patients. And amongst insulin, it is the basal bolus therapy for non-critically ill patients and IV insulin infusion for critically ill patients, which is the gold standard. OADs, as we mentioned, are generally not recommended and they are never started in the hospital. If patient is already on and if patient is admitted for some very mild illness, probably in some of the cases we may continue, otherwise we need to discontinue them. So let us talk about the basal bolus regimen and the role of newer basal insulins now. We know that there are 3 or rather 4 basal insulins available, 5 to be more specific, starting from the NPH, which is not at all actually a basal insulin because it has peak at 6 to 12 hours. Insulin Detamir, again, that is less popular amongst the basal insulins in the non-pregnant patients because it does not last for 24 hours. So the 3 basal insulins which we commonly use are Glargine U100, Glargine U300 and Deglued. Amongst them, if you look at these studies, the RCTs like Begin, Switch and Devote had shown that Deglued is non-inferior to Glargine U100. And if you look at the Conclude study, there Deglued was shown to be superior to Glargine U300. The real world evidences with Utreat, Confirm and Reflect also showed that Deglued, the A1C reduction was superior with Deglued compared to U100 or U300 of Glargine. If you look at fasting, again Deglued U100 was superior to U300 or U100 of Glargine. And as far as the dose was concerned, compared to the other insulins, Deglued was also required in the lower dosage. Very importantly and universally, the reduction in the hypoglycemia rate was seen across the spectrum in all the studies, whether they were randomized control studies, whether they were real world evidences, or whether they were comparing it with Glargine U100 or 300, hypoglycemia risk was lowest with Deglued. So needless to say that time and again it has been shown that Deglued is associated with low risk of hypoglycemia, equal or probably superior control compared to U100 or U300 Glargine. Now let us look at the time action profile of different basal insulins. Deglued has onset of action within 0.5 to 1.5 hour, fastest amongst all the basals. Glargine U300 2 to 6 hours, and Glargine U100 2 to 4 hours. So surprisingly, Deglued, though having a longer duration of action, the onset of action is actually quicker than U100 Glargine. So the quickest onset of action amongst all the basal insulin, it is with Deglued and not with insulin Glargine U100. Time to steady state. Whenever we thought about using Deglued in the hospital patients, the first thing which came to our mind was whether it will start working on the next day or will it take 3-4 days before achieving the steady state. But if you look at the steady state required for the other insulin also, for Glargine U100 it is 2 to 4 days, Deglued 2 to 3 days, and U300 is 3 to 4 days. Which means that whether you are using U100 or U300 Glargine or whether you are using Deglued, it requires 2 or 3 days before you achieve steady state. So all the insulins are same as far as achievement of the steady state concentration is concerned. It is not that Deglued requires longer time compared to U100 Glargine. So the myth that Deglued will not start working on day 2 is actually not true. Because you can see from this slide and this study that there is a quick attainment of the glucose target with Deglued. You can see Deglued reaches steady state in 2 to 3 days, but 70% of the serum concentration is achieved by day 1 and 90% by day 2 or 3. So which means if you are given say 12 units of Deglued today, by tomorrow at least 8 units would have started functioning. May not be sufficient, but you can always up titrate the dose on the second day. There are now several in-hospital trials using Deglued compared to Glargine. And you can see from this slide that even on day 1, the baseline of 219 fasting comes down to 180 and the target can be achieved quickly by a rapid up titration of Deglued insulin, same as you can do with Glargine U100 insulin. So then what are the advantages of using Deglued compared to Glargine? Well, this IDEO study, which was an hospitalized patients prospective observational study, it was an open label study where it was seen that fasting was much better with Deglued, pre-dinner was much better with Deglued, bedtime glucose was much better with Deglued with statistically significant p-value. Only pre-lunch was better with insulin Glargine. The rest of the things were better with insulin Deglued for the hospitalized patients. And that too with much lower rate of hypoglycemia. You can see here that amongst the Deglued patients, the incidence of hypoglycemia is less compared to Glargine, and the severe hypoglycemia is seen in 2 patients, in 2% of the patients with Glargine and none of the patients with Deglued. So Deglued demonstrated good efficacy with much lower risk of hypoglycemia compared to U100 Glargine. And I always remember when Bansi mentions that ideally these studies should be switch studies, and here is the result of the switch results. When patients on Glargine were switched to Deglued, you can see that the number of 25% and 5% came down to 15% and 0% after the switch from Glargine U100 to Deglued, which means that those patients who were on Glargine when switched to Deglued had much lower risk of hypoglycemia. And overall predictability and the variability also was much better with Deglued. You can see here before the switch or before they were on Deglued, when they were on Glargine U100, the standard deviation is very large. The time in range is very low compared to when they were switched to Deglued. The difference you can see, there is a wide interval here and a very narrow interval when they were switched to U100 Deglued compared to U100 Glargine. There is a lower within day glycemic variability with Deglued than Glargine. Glargine we know is not a totally peakless insulin. The best efficacy of Glargine is within first 6 hours followed by the next 6 hours. And in the last 6 hours the efficacy is much less, almost 50% less compared to the first 6 hours. So you can't say that Glargine actually lasts for 24 hours with similar efficacy. In the last 6 hours the efficacy is much lower. Compared to that, Deglued is almost uniform. You can see 23, 28, 26, 23, which means
Deglued has much less variability compared to U100 glargine. What about comparing it with U300 glargine? There also you can see that the best efficacy is within first 6 hours and the efficacy in the last 6 hours is not comparable to what you see in the first 6 hours. As against that, as mentioned in the previous slide also, the efficacy of Deglued is uniform with least variability. So Deglued is the insulin which is associated obviously with the least variability. This is almost repetition that both U300 and U100 glargine are associated with more variability, whereas Deglued's efficacy remains uniform throughout the 24-hour period. Moreover, in the hospitalized setting as well as in the outdoor setting, there is more flexibility when you are using Deglued. You need not stick to the same time every day. There is a flexibility of 6 to 12 hours with Deglued. Well, in the hospitalized patients, this may not be very important, but in the outdoor setting, this will have great impact. We can use Deglued in wide range of population, whether patient has controlled diabetes or uncontrolled diabetes, whether the patient has renal impairment or not, whether the patient is having hepatic impairment or not, whether the patient is elderly, because there you will have less risk of hypoglycemia, which will have significant advantage in the elderly people, and even in the pediatric patient one can use Deglued. So to summarize, we know now that optimum glycemic control is associated with improved hospital outcomes. Basal bolus therapy is the therapy of choice for the management of hyperglycemia in the hospitalized setting, and evidence from the hospitalized patient studies have shown that Deglued provides quick attainment of the glycemic control with less risk of hypoglycemia compared to the other basal insulins with the lowest glycemic variability. Thank you very much for your very kind audience. Thank you, RSSDI, once again. Yes, straight away. I thought it would be after the
Okay.
symposium.
Question from the
Yes. If there are no questions, I'll ask you a question. How many of you use U100 Deglued? U100 is the only available in the hospital. Yes.
I mean, why not you give them slightly higher dose on day one? I mean, now we are involved with the Icodec, which is a long
Yes.
insulin, and the dosing which is to be done in that, we start with a higher dose because to achieve the concentration, the serum concentration. So as you have said that 70% will be effective within 1 day. So suppose you want to start a patient with a 12 units, why can't we give the patients on that day 18 or 20 on the first day, and from the second day onward? Because there is no stacking, there is no, I mean, you will not have the hypoglycemia just because of the higher dose of the insulin on day one. So is it possible to start the patients with a higher dose? We don't have the data, but what you do?
Yes. So case to case basis it can be done, but the general recommendation for starting of Deglued dose is 10 units universally, I think. Whereas for glargine it is 0.1 or 0.2 unit per kilogram. So with glargine you can do ethically. How about Deglued? I have no answer to that, but generally I start with 10 or 12 units. Yes.
In hospital,
Yeah, that's right.
you want to
So if patient is already on some other insulin,
that,
yes.
the basal insulin patient was taking on IV insulin.
Yes.
Like suppose patient total requirement you thought of 15 units. Now you want to give the patient basal insulin on the day of stoppage of the IV infusion pump. So why can't we start a slightly higher dose on day one to achieve the similar type of efficacy, and next day your fasting sugar should get controlled? So why can't it be given?
Yes, I agree with you that if patient was on say 30 units of insulin prior to switching them to the basal bolus therapy, 15 units you give as a basal and 15 as bolus in 3 divided doses. If you are starting with Deglued, you mean to say that you start with 20 units on day one, and then yes, it can be done, but I have practically no experience in doing that. If someone has,
Because with the recommendation is also
yes,
there is no recommendation, but for Icodec there is a now because it's a longer.
it's a very ultra long acting.
And
That's
we are
why.
doing a clinical trial. The recommendation is also on day one. You use the higher dose because for next 7 days. 1.5 times. It's a 1.5 times. The loading dose, and then you continue with the same dose which is required for the
See,
next.
we have been using the Deglued for preoperative patient on the eve before surgery. Those who are going to be on Nielsen house for about 18 hours. where we are giving a dose of a shot of Deglued very regularly. This is what I tried in about 5-10 patients, and we had severe hypoglycemia on the next evening. So I think it is not worth trying, at least in those patients who are going to be nil by mouth. Otherwise, it's a very wonderful drug for a pre-operative.
No. So you are saying that the patient is getting hypoglycemia in 36 hours?
Yeah.
But what about the next day morning? Because you have posted the patient for next day morning surgery
Nothing,
and you
no
want the
issue.
sugar
No
less than 130.
No issue.
No
They are well controlled. Absolutely. The issue is if you give the regular dosage, they would have enough basal insulin to prevent rest of the thing. But the moment we gave 4 units more, they had hypoglycemia next evening.
So the myth that Deglued will take longer time to achieve the steady state compared to Glargine is not true. Yes, all the basal insulins will take some time. Yes. Yes. Yes, sir. U300 can also be used but does not have a specific advantage over Deglued U100, as I showed in the slide that the variability of U300 is almost comparable to that of U100 except in few studies. So I think both are comparable, U300 and Deglued as far as the variability is concerned. But the studies which I showed in the hospitalized patients, Deglued has probably more data. Compared to that, U100 has significantly large data, but U100 is not a peakless insulin. The efficacy does not last for 24 hours, especially when the dosage is small.
Sanjeev,
Yes.
I am having a question. What we see in our ICCU that when patient came with hyperglycemia 200 to 400 and patient is a RTF on ventilators. So could we put the long-acting insulin day first?
I think this patient should be on IV insulin infusions and not on basal bolus or subcutaneous
Rather,
insulin. So
short-
patient who is on ventilator, critically ill, all these
short-
patients should be on IV infusion and not on the later on, once their condition is stabilized, they are off ventilator, can be started on oral feeding or rice tube feeding, we can switch them to. But any patient who is on parenteral nutrition, any patient who is on IV infusions should be on IV insulin infusion and not on the basal bolus therapy. So even a basal shot in addition to IV insulin, some of us use that, but I think is not having any evidence to do that.
I request Dr. Gadia to file it. Very happy to see the all seats fully occupied. Really very nice.
Now I would like to invite Dr. Bansi Sabu for co-formulation insulin in India reality from published evidence to practical experience. I think Bansi doesn't require any introduction to this august audience. He is the Narendra Modi of diabetes.
So, thank you. So before I start the talk of co-formulation insulin in Indian realities, I just want to inform that for in-hospital hyperglycemia in India, we are going to collect large data from more than 100 multi-speciality hospital, the status of glycemic control in our country. And that's what the program which we have decided before just 10 days. And we will be also approaching all those consultants who are taking care of large multi-speciality hospital, which is more than 100 bedded hospital. And for 1 day data, we just want a cross-sectional data for those patients who are admitted in hospital more than 48 hours, what is the status of their glycemic control. With this, I thank Dr. Urman Bhai, who is RSSDI Gujarat State Chapter Chair, Dr. Pratap, Scientific Chair, and Dr. Desai, Organizing Secretary of this meeting, for giving me an opportunity, and thanks Novo Nordisk for this opportunity. What I am going to talk the co-formulation insulin in Indian realities. I'll be talking some published evidence to the practical experience, and what my practical experience I will also show. I'm not a great supporter of a co-formulation for an intensification, but I do start the patients on a co-formulation on a single dose or once in a day. I have a disclosure which I have already made that this is a supported by industry, no notice. I will start my agenda with the type 2 diabetes in India, the key challenges which we have. Then we would like to talk about the innovation that suit best to the Indian reality, and then simplifying the insulin regime, that my experience and practical recommendation that will end my talk. We all know that high carbohydrate diet is a common Indian reality, and we all know from these two major studies, the pure study which is by Dr. V. Mohan, a popular study, pure data from all over the world, and same the starch study which is done by Dr. Shashank Joshi from all across the country. And what is very important part of it, that we South Asians, what we consume in day is only carb, carb and carb. So I mean, most of the time what we are eating, all of you agree that in morning breakfast, this is a pure vegetarian restaurant where we have taken only carbohydrate and we could not eat any other thing other than the carbohydrate. Unlike Western population, it is the postprandial glucose is a major challenge at any level of HbA1c. So we have the data which shows that the patient whose HbA1c is more than 8.5, ideally you should try first fixing the fasting. That was what the concept is been given by the Western population or even the ADA ESD. But in India or in the Asian population, even at any level of A1c, even you have a patient with an A1c of 7.5 or 8, it is not the post meal, it is every time, even for 8.5, 9, everywhere it is the post meal glucose level is always a challenge for our diabetic patients, and that's a what very specific for Asian population. So the key realities in managing diabetes in our country, one is we have high baseline PPG. So you may have a patient with 7.5 HbA1c and who is fasting and postprandial both are uncontrolled, and you may have a patient with 9 HbA1c who is fasting and post meal both are uncontrolled too. You have a high intake of carbohydrate. That's a reality that what 70% of our food is contains only the carbs. We have a typical Asian phenotype. Just before Rakesh had talked about the higher waist circumference, more total visceral fat, hyperinsulinemia and more insulin resistance. We have a delaying insulin initiation therapy. That's very true. There are 2/3 of diabetic patients are not controlled. We have not the patients on quadruple therapy. We are having 5, 6, 7, whatever the number of medications which are available. We see even a 2 SGLT2 in a one prescription and 3 gliptins in a one prescription too. So we are having all different type of combinations are available in our country, and the same prescription may have multiple oral anti-diabetic agents, and we just want to delay the insulin therapy, and we need a very simple, convenient insulin regime, and that is what we have. Already we have premix insulin, and that's the reason that many of our patients are put on a premix insulin across the country, because that is the most simplified way of treating type 2 diabetes when we are initiating the patients on a insulin therapy. And which insulin regime should suit best? I think probably basal. That is what they recommended all across the world, because we want fixing the fasting first and then your post meal will follow. So you will have a better control of fasting and then your post meal glucose will also get control. But will it be suitable for the patients who are eating too much carb? Will it control the post meal glucose level? Will it be for those patients who have already delayed insulin therapy? It means already the patient with 9 HbA1c, and will it have a total control? So I mean, you have a basal insulin, which is an ideal to start with these patients because it's very easy, but we have already starting a patient who is 9.5. who is with a 5 years of diabetes, uncontrolled diabetes of 5 years. He was already eating the carbohydrate only. His major challenge is the post-meal glucose level. So should we start these patients only on basal? And we have the data that those patients who are started only on basal, only 30% of the patients, even that is the data from Western population, they achieve their HbA1c less than 7. So if I put the similar data from India, probably only 10% or 20% of our patients, only by putting them on a basal insulin will able to control. So probably it is not the ideal one for an Indian situation. We are coming for that what we should do for an Indian situation. Can we start these patients on a co-formulation? So I'm not talking of a premix insulin. I'm talking of a co-formulation which is different than what premix insulin. And a co-formulation can work because it has got a short-acting insulin which is available along with a longer-acting basal insulin analog. Both are combined in a one shot, and that can be used to treat these patients where the post-meal glucose level is high, and they also give you a basal component also. So let us understand more about co-formulation. I am not going the PKPD part of it because we know that it's a 70% is a ultra long acting. Already Sanjeev was talking about the Deglued, and then we have a short acting aspart also a part of it as a 30%, which is that what the co-formulation is there. So I'm not going in that detail, but it is the combination of a short acting insulin analog with a long acting insulin analog, and this is what a distinct a prandial control and a glucose lowering effect at a basal level. So you have a 24 hours a fasting can be controlled, and a one peak, particularly when you are giving that particular peak, can be controlled with the using this co-formulation, controlling that distinctly that prandial control also. If you are giving before breakfast, if you are giving before lunch, at least that peak can be controlled with that 30% co-formulation. Now this is in one paper which we are trying to use for the patients to whom can we start insulin Deglued along with aspart in a single dose with oral anti-diabetic agents when it was compared with a Glycine 100 units with oral anti-diabetic agents. And now I am again putting this is a single shot of a co-formulation injection. It is not that I am putting it a twice daily, and when we are comparing it with Glycine alone, so that when it was comparison, it had shown there was 1.4% superior HbA1c reduction and fasting plasma glucose reduction which both with Glycine and with the combination of Deglued aspart was same. And this is expected because you are going to use the basal insulin, the dose of Glycine and the basal insulin component of this co-formulation are same. So you have a similar HbA1c fasting plasma glucose get controlled, but you have a better HbA1c control because the one component, the 30% of the short acting insulin is going to cover that post meal glucose part, and that's the reason there is a superior HbA1c control was found with this co-formulation. This is the data which had talked about the estimated treatment difference between the post meal glucose that was 57 milligram per deciliter. Just, sir, I am in a talk. I just call you back. I call you back. So this uncontrolled postprandial glucose excursion can lead to oxidative distress. That is what we know about the oxidative stress and endothelial dysfunction, and leading to macro and microvascular complications. So you are not to just control the fasting plasma glucose, you need to control the fasting and post-meal glucose both. This is one more comparison which is talking about the co-formulation Deglued aspart versus once day basal insulin, and you can see the patients on Deglued aspart found to have 72% patients achieve targets in compared to the patients who are put on a single dose basal insulin. So I mean, instead of that putting a patient on a single dose basal insulin, if you compare these patients with a combination co-formulation, you will find, particularly patients if you are using this molecule before the major meal, you will find the post meal glucose control is better. This is one more comparison where I had put on the left side multiple clinical trials which had happened in 2016 to 2019, and they all favored the patients who were put on a Deglued aspart combination in compared to the patients only on basal insulin, and the mean self-measured post-meal glucose control was also better in the patients who were put on a IDEG aspart co-formulation in compared to the patients only on basal insulin. This is IDEG aspart was associated with significantly greater time in range in compared to the patients who are on Glycine U100 without an increase in time below range. So what is more important, we started using the concept of time in range. Like you are putting a patient on a continuous glucose monitoring, how much time in a day a patient is spending his time between 70 to 180. So when you are putting a patient on a Glycine in compared to a patients who are put on a Deglued aspart combination, the one thing, how much more time the patient is spending in time in range, but at the same time, whether by putting the patient on this Deglued aspart combination, will it increase time below range? So it should not increase the hypoglycemia, but rather it should improve the time in range concept. So IDEG aspart was associated with significant improvement in time in range without increasing time below range. So that's very important, without increasing any hypoglycemia. This is a smart study design where the patients were type 2 diabetes, 1029. Those patients who were receiving IDEG aspart, data was collected on a baseline 3 months, 6 months and 12 months. It is a multicentric study, prospective, single arm, observational, post-marketing study. Many of you might be the part of it. The key inclusion was men, women with diabetes, more than 18 years or adult, scheduled to start the patient on a IDEG aspart based on the clinical judgment and change in HbA1c level. You can say IDEG aspart showed effective control of HbA1c with an HbA1c reduction of 1.8%. Change in fasting plasma glucose after end of treatment was 50.4 milligram from the baseline HbA1c. Change in postprandial glucose level was again significantly decreased, particularly post lunch and post breakfast. It was decreased by 77.8 and 84 milligram with the patients who are put on IDEG aspart combination. The reduction in number of hypoglycemic episodes. So when you are trying to achieve a good control, you don't want increase in hypoglycemia episode. So one very important, when you are comparing two molecules and two insulin, one thing you want to have a better control of A1C, better in time in range, but without increasing the risk of hypoglycemia, without increasing the risk of hypoglycemic episodes, and that is significantly reduced with the patients who were before putting the patient on an IDEG aspart, when they were on whatever the insulin, when they put on the IDEG aspart, there was improvement in HbA1c, but there was no increase in the risk of hypoglycemia or risk of hypoglycemic episode with this. And then I will come with the last part of it, that how simplify you can use and with this convenient solution. All those who are already on a premix in Indian market, there are premix insulin which is very popular in our country. Can they be shifted from the same premix to co-formulation? Yes, it can be done. I don't do personally in my clinical practice. I would like to put those all patients on a basal bolus therapy, but if your patient is not convenient, you are not able to convince your patient to putting from premix to directly on basal bolus on a 4 shots, then this could be a good solution to put the patients again with the same dose with the co-formulation, with decreasing the risk of hypoglycemia and for a better control of diabetes. And if I put the patients only on a single shot, and that is what I do in my clinical practice, I use IDEG aspart as a basal insulin analog only. I use it only once in a day. I had never prescribed IDEG aspart twice daily. I put the patients on a, like we are putting the patients as in a basal insulin. We start with a once in a day. You can decide which particular time. It could be before breakfast or before dinner or before lunch. Whichever the biggest meal of the day, you start with the patient on that particular time, and you again chase the patient with the fasting plasma glucose. If fasting plasma glucose is higher, you can increase the dose of this same DEG and aspart with +2 as we do with the other basal insulin, and try to achieve the fasting plasma glucose, and then you try to see the post meal glucose level. I am sure the patient which is put on the biggest meal of the day, the post meal of that particular time will be definitely well controlled. The other post meals can be controlled either with oral anti-diabetic agents or by nutrition counseling or by stopping or then decreasing the carbohydrate content in their diet, and that is what we can do for these patients. Considering the IDEG aspart in patients with type 2 diabetes, those patients whose post meal glucose level are high, patients are failing to achieve the glycemic control, but one more advantage which is not been written or not been prescribed, one flexibility with IDEG aspart. Like suppose you started a patient with a IDEG aspart every day before breakfast, and patient is having good control of diabetes. The post breakfast is fine, post lunch is fine, post dinner is fine, and lunch and dinner you have asked the patient to reduce the carb content of the diet. As the Deglued is such a flexible molecule, even after 12 hours you see there won't be any difference. And suppose on that particular day patient think that, you know, today my dinner will be very heavy because I am going to have a feast at my friend's place, and that could be the reason. You can tell that instead of that day giving the patients before breakfast, patient can switch on that particular day even before dinner also. Even he has taken in the morning for IDEG aspart before breakfast, he can again take dinner time also, and next day he may omit his IDEG aspart for next day breakfast too. And that I do often for those patients who are on a single shot of IDEG aspart as in combination, as a co-formulation, as an insulin therapy for type 2 diabetic patients. let me have my experience, which I have done for a patient with a continuous glucose monitoring, a garden variety of type 2 diabetic patients who need insulin, who is on a multiple oral anti-diabetic agents, a 62-year-old male with 9 years of diabetes with a HbA1c of 8.5, uncontrolled diabetes, explained the patient about the self-monitoring, also explained the patient about the continuous glucose monitoring, and we asked the patient, let us do your continuous glucose monitoring. And this is the data on first day. You can see his all post-meal glucose level are high, and his fasting is also high. On the first 4 day, you can see the report that his post meal as well as fasting both are high. So the patient is to be started on insulin without any doubt, and we started the patient on single shot, which we have decided. On day 4, we asked the patient that you try to control your meal, try to content of carbohydrate are to be significantly reduced, and you see that whichever the meal which you can do, please do for lunch and dinner. At least if you are taking 2 chapati, make it 1. The 1 should be again with a multigrain. Try to reduce your simple carbs as much as you can do. And we started the patients after explaining the patient that we can start with a lower dose of Rhizodex, which we optimized on day 8, and the fasting was not controlled even after 8th day. You can see from the 9th day onward, his fasting started getting control, and at the same time, he was still having the post breakfast was the biggest peak of the day. Even Indian patients may not have a very big breakfast, but still our post meal, if you do their continuous glucose monitoring, you will find that post breakfast peak is the biggest. And we have started these patients only with the pre-breakfast single dose co-formulation before breakfast, and you can see after 9 days his fasting as well as his post breakfast peak has gone. So patient was on triple drug oral anti-diabetic agent, along with patient was put on a Rhizodex before breakfast, and you can see on 9th day, 10th, 11th, 12th, 13th day is almost flat with no peak post meal, neither for post breakfast, post lunch, or even post dinner. With this, to summarize my talk, a high carbohydrate diet resulting in high post meal glucose level, which is a common Indian reality. We have our patient with 8, 8.5, 9 HbA1c, and if you just check their post meal glucose level, all of them will be having very, very high. Insulin therapy is really complex. It has got its own limitation, and that's the reason it's not very popular. Only 10% of our patients actually getting insulin therapy, and still insulin therapy those patients who are getting is not optimized. So there is a data from India that those patients who are on insulin therapy, still their glucose is not good control. And this is also one of the reasons that many of your patients may deny that even my cousin, even my distant auntie is also taking insulin, but her sugar is also not controlled. So why I should be put on the insulin too? As a result, the insulin regime that fits into patient life can help for better glycemic control. And now we have a insulin which can fit into the lifestyle of the patients. Instead of asking the patient to change his lifestyle, you can give him the therapy in such a way that his lifestyle can be adjusted along with the insulin therapy which you want to give. IDEC Aspart is a simple, a convenient solution which offers total control for a fasting and post-meal glucose level in a patients who are uncontrolled type 2 diabetes who are on multiple oral anti-diabetic agents. With this, I thank once again, thanks to chairpersons and all the audience for your kind listening. Thank you.
Excellent elaboration of the topic. Now I invite the audience. Is there any question?
Yes, sir.
Because the insulin earlier to Rhizodex.
So patient was not on insulin. No. Patient was not on any insulin.
Not a, only triple drug.
It was only on triple. It's for 4 drug.
4 drugs.
4 drug.
That's what I saw. Sir.
Yes.
And how do you tackle the economics of this switch from a premix to Rhizodex in your OPD, sir?
So, to be very frank, those patients who are coming to my OPD, if they can afford me, they are affording. So, I don't mind that. If somebody is not affording, then I'd say that why you have come here, because then you come to Jivraj Mehta, and I don't see non-affording patients in my OPD. So if somebody can afford me, then he has to be affording, otherwise he can't. So the point is very clear for the patient's affordability, and I always remember that Sanjeev lecture long back he has talked, the cost of therapy of diabetes is still not very costly in compared to the cost of complication which he is going to have. So how you explain the patient, that is more important. Like if you explain the patient, then in long term, in 10 or 20 years or 30 years, what the complication which you are going to have in compared to the patients who is not going to use the best therapy which is there, I think probably the complications is going to cost him much more in compared to the therapy. So the premix insulin which is available in India, the market of premix insulin is big. But what's the point? I mean, if you given the patient a premix insulin, in a year he is going to have 2 hypoglycemia, 3 hypoglycemia once in a time, getting admitted and still keeping HbA1c of 8.5. I mean, it does not make any sense of keeping the patient HbA1c of 8.5, giving him 2 shots of injection and also getting hypoglycemia. Yes, Sanjeev boss. Yes, sir. Please.
As you mentioned, you have used only once in a day Rhizodex, but we have used twice in a day with a very wonderful result.
So, sir, I don't deny, but I tell you, for a premix insulin, I am obsessed that it should not be used. See, if I use the premix insulin or a co-formulation, suppose you are going to use.
I agree with you. When you are using basal bolus therapy, it is much better than the twice a day premix insulin. But point is that you can still use Rhizodex twice a day in a type 2 diabetic patient for a good glycemic control. That is what is the message is. Why we have seen a number of patients. Then second important thing is that
Sir, with CGM?
With CGM.
So the point I am telling you, see, one with the background, if I say with the background that India is a country where the post meal is a major challenge, India is a country where the carb content is a major challenge, India is a country where the prandial insulin requirement is more in compared to basal, then with this background, if I am putting the patients on a twice daily a premix, whether a co-formulation or premix, even if you are using 20 units or 30 units, you are going to use 70% of that part as a long acting, only 30% as a short acting. If the same patient you are shifting from premix to basal bolus, you will find their basal requirement is much less in compared to their prandial requirement. And that's the reason it will not fit scientifically. It may fit for one particular patient, while giving them more basal insulin, patient might have good control, but we don't have the data to support it by continuous glucose monitoring. The second important point is the patients who are on insulin therapy in India, in a real world data of 2021 with the Diabetic Care, which is study done is a post-marketing survey. Mohan was the chief investigator. It had shown that patients on insulin therapy also keeping their HbA1c around 8.5. So, I mean, if you can achieve a patient sugar less than 7.5 and then you do a continuous glucose monitoring and finding that these patients are not getting hypoglycemia, itself is a real challenge, and we don't have data which is published. Most of these data which are published are showing just that they are achieving a good control of diabetes, and they compare between 9 and 8. They are not comparing that how many of them are achieving less than 7 and what is the risk of hypoglycemia by doing continuous glucose monitoring.
There is one point to that when they tried for increasing the dose of aspart, they did not make it successful, and they stick to the combination of
Yes.
That was one thing. But second thing, what we are talking here is that it is not the only insulin. Patient is on drugs which are addressed like DPP4 inhibitors or alpha glucosidase inhibitors, and many of these drugs, they will take care of the...
I agree. So that is what we are doing with the one single shot also.
The point is that we can use twice a day co-formulation for good control of diabetes in a type 2 patient.
So,
that is one thing. Second thing, another important thing is that in those patients who are on basal bolus therapy, even you can use with plain analog twice in a day plus once a day.
That I use. That we do use.
And that will also help.
So the patient who are to be intensified after Rhizodex, I am going to put the patients on other 2 short-acting insulin analog and keeping the same once in a day. So I mean, whatever the Deglued dose or basal insulin requirement, I will decide with that combination with co-formulation, and remaining I can control it with giving them a short-acting insulin analog before other meals. Sanjeev bhai, your comment.
So my question was on the same line as Dr. Navneet Bhai, and I agree with you that there is no point in using, except in selected patients, twice a day Rhizodex. If patient's fasting remains still high, we can increase the dose of Rhizodex in the morning. And if postprandial other meals is high, we can always use another short-acting insulin. Now, between this and short-acting insulins, if you are using Rhizodex, which rapid-acting insulin should be preferred? Should it be only no rapid, that
No,
is Aspire,
I don't use.
or Fias?
No, even I don't use Fias also. I go with the other insulin. To be very frank, here in the
So
audience,
the pen is different.
so the pain is different because I don't want my patient to get confused. If I am putting the patient on a Rhizodex single dose and I want to use 2 short-acting insulin analog, I may put the patient on Humalog because the pain is different, because that makes the patient considerably. This is to be taken before breakfast and before lunch, and before dinner the patient has to be on Rhizodex. I don't put, and I every time whenever I putting the patient on a basal bolus insulin therapy, I try to use 2 different type of pain and 2 different type of companies also. There is nothing like that the patient has to be on the same company.
Yes, but there are no studies. Someone may argue that there are no studies where you have given no rapid also as a part of Rhizodex
okay.
and Lispro also.
See, the study is
Nothing is
fine.
wrong.
Nothing is wrong in it, as long as you are not doing wrong. The one more thing is about the Rhizodex. I am telling you, like why we should use the human mixtard we were using twice a day, because the NPH insulin was not taking care for 24 hours. So NPH has to be given twice a day, and that was the reason we were using the NPH and regular acting insulin in it twice a day.
50-50 was available.
So we can use it 3 times
So I'm
daily.
adding to your argument.
So we are using that NPH and regular. We were using the 50-50 since long. Human mixtard 50-50, human insulin 50-50, Humalog 50-50 were using for that.
70-30 issue was also gone with 50-50 available.
We had used in years.
So you are making a compulsion for Novo to have a different color coded.
Yes, it has to be.
Because
It is there with the Sanofi. It is here with the Sanofi.
Yeah.
I use with the Lantus and Epidrap with the 2 different color pen, because that really makes sense. It really makes sense, because there is lot of confusion with the patients if you are using the same pen which giving the Fias and Tresiba. Even if I am putting the patient on Tresiba, I will not put the patient on the Fias. If I want to put the patient on Fias, I will ask the patient to go for a disposable pen. I will not make the confusion between 2 different pens.
And another last comment I want to make, the most beauty of co-formulation is, in comparison to premix, is that these are the different formulation, in the sense when you take it out from the freeze, it is still, you don't have to mix and do something. Many a times what happens, patients do not do that. They forget to do that, and then the bioavailability would be different with the premix formulation than the co-formulation.
So co-formulation, that's an advantage in compared to the premix insulin. But I don't use the premix also. By all means, I can say here that I don't use the premix. Not a single patient on premix.
I think if there are no questions, we can ask.
Thank you, sir.
One of the chairperson to felicitate Bansi, Dr. Bansi, I'm sorry. Bansi, Sanjeev, etc. have been so much good family members that I forget to add doctor to the. Can I request Dr. Jitendra Patel to felicitate the chairperson? Oh, sorry. Take lecture back. I'm sorry. Yeah. I forgot to see it. Sorry.
For the third lecture, I invite Surat. He is a consultant diabetologist and endocrinologist, postgraduate diploma in endocrinology from University of South Wales, UK, and recipient of award for excellence in diabetes care by RSSDI 2019. Over to Dr. Pius.
Yeah. First of all, thank you RSSDI for inviting me for this lecture. And as Urman Bhai missed my lecture, because 2 lectures were on insulin, and the third lecture is totally opposite to that. I am going to talk about peptide like insulin, but not as an injectable, but as a pill. And why this is a need of hour? Because 100 years of insulin discovery is there. We are on the 100th year. Still, we are not able to achieve insulin as an oral pill. But at least with a first peptide in pill, we have now the things open for more and more innovation, and maybe in future we may have insulin also as a peptide. So we will not to worry about premix insulin or basal insulin or co-formulation. These are my financial disclosure. So why we want more and more therapy for type 2 diabetes, and especially now we have a very good agent, that is GLP-1 analog. And I will tell you, before it came as a pill, the acceptability was very less, not only because of the cost, but because it was an injectable therapy. So people think that it should be used at last before starting insulin. Now we have this peptide available as a pill. So we want to address the octet of type 2 diabetes, and then we will talk on innovation of century, that is oral semaglutide, and the data supporting that. So as far as ominous octet, I think as an August audience, you all are knowing about this differentials ominous octet, where multiple pathophysiology are responsible for type 2 diabetes management. Out of that, if we go for GLP-1, GLP-1 will have incretin effect. So that is from intestine. So it will delay the absorption. It will have effect on beta cells. So it will have glucose sensing insulin secretion. It will have action on alpha cells. So it will reduce glucagon secretion. It will have effect on lipolysis because it is causing weight loss. It is having effect on brain, which no other OHA at present able to, except that bromocriptine, that neurotransmitter regulation, and also acting on liver because it reduces hepatic blood glucose output. So sparing skeletal muscle and kidney, 6 out of 8 pathophysiological mechanism is been addressed with this polypeptide. And this peptide is oral semaglutide, which was available before as injectable also, not in Indian market. Indian market semaglutide directly came as a oral formulation. But why this is needed? There is always an unmet need for safe, non-invasive and convenient mode of therapy, because many times patients are not compliant enough because it is injectable. So we have a challenge that if we want a GLP-1, which is there since sitagliptin was launched, I think liraglutide almost 10 years. Now it is also going to be off patent, but all companies are behind sitagliptin when it is getting off patent, not liraglutide. Why? Because it's a pill and this is an injectable therapy. It is difficult to make this injectable to oral because enzymatic degradation will degrade that peptide in stomach only, and that is due to low pH and proteolytic enzyme. After that, being a bigger molecule, permeability will be a question that will also reduces an absorption, and that's why when it reach into the circulation and to the target tissue, it will have a very low amount which is really bioavailable, and that's why this limited absorption is causing problem. Semaglutide as such a peptide which is having 94% homology with human GLP-1 and with T half-life of 1 week. Here we have one amino acid which is replaced at position 8 at position 34, and there is a fatty acid chain which is attached to lysine at the 26 amino acid, and this is now combined with an agent that is called SNAC, and SNAC is an absorption enhancer which is a patented molecule which initially was invented for B12 absorption, the technology which now is helping to increase and enhance the oral bioavailability of semaglutide, and this is the combination of semaglutide with SNAC is the key for an oral formulation. Now oral formulation of semaglutide is available with us since end of January 2022, but before that we have number of clinical studies which are showing good result with oral formulation, safety result with oral formulation, and CVOT result also. So we have 24 clinical pharmacological trial, 1 phase 2 trial and 10 phase 3A trial, and we have almost 10,000 patients which were enrolled for this semaglutide study, and 5,707 patients were exposed to oral semaglutide. We have one study, Pioneer 1, comparing it with placebo. We have Pioneer 2, 3, 4 comparing it with SGLT2, DPP4 inhibitor and other GLP1, and with Pioneer 7 combining with a flexible dose adjustment versus DPP4 with extension. We have data of using this with insulin in Pioneer 8. We have few Japanese study also, and one ongoing study, that is SOUL study, for superiority result for CVOT. And before that, the result which we already have is Pioneer 6, that is the first CVOT study with oral semaglutide. Pioneer 1, Pioneer 2, 3, 4, 5, 7 and 8, you can see the whole plethora of various studies where you can see the HbA1c result which we get is around 1.2 to 1.5 percentage, which is much better than other OHs, even as a monotherapy, as an add-on to insulin also. So it is not that even we are using this at a late point where we are already have patient on insulin therapy, it can reduce HbA1c up to 1.2 to 1.5. And see the number of patients who achieved less than 7 HbA1c, 72% and 80% with 7 and 14 milligram of semaglutide. Semaglutide, here we have 3 doses, 3 milligram, 7 milligram, 14 milligram, that we have to uptitrate. And here with 7 and 14, which are the routine dose, we can achieve at least 7 patients out of 10 who have been put on semaglutide will have HbA1c less than 7 as per these studies. And with 14 milligram of oral semaglutide, patient who are having baseline HbA1c of 9, we can achieve HbA1c like 2, 2.2 or 2.5 also, which is the case with most of the things, that when the entry level HbA1c is high, you can have even better result with this. But at the same time, the benefit of GLP-1 is not only HbA1c control. The benefit of HbA1c control along with weight loss, and you can see this causes weight loss which is far superior than even SGLT2 inhibitor. It is superior to liraglutide, which is short acting GLP-1 which is given daily, and it can cause also weight loss in patients who are on insulin therapy. That is the advantage of using this drug with a better HbA1c, stronger HbA1c control with weight loss. And if we see both, so patient who has achieved HbA1c more than 1% reduction, and on the other side weight loss of more than 5%, and you can see the data of Pioneer studies where oral semaglutide 14 milligram was far better even than empagliflozin, liraglutide, sitagliptin and placebo. Everywhere it was almost 2 to 3 times better result than SGLT2 and DPP4 inhibitor. As far as CVOT outcome study is concerned, we have Pioneer 6 data where it was found to be non-inferior with significant HbA1c and body weight reduction. There was 21% risk reduction, but statistically it was non-significant because it was crossing confidence interval from 0.57 to 1.1, and that's why the hazard ratio 0.79, which was favoring semaglutide, was statistically found to be non-inferior. But at least at this point of time, we know that semaglutide oral molecule is CV safe, and injectable superiority has already been proven. As far as taking this drug is concerned, I will say this is very important slide for you all in clinical practice, because this is the drug which is attached to snack which enhances absorption. So it is to be taken in a specific way. That patient should take this medicine early in the morning just after waking up, and that should be with a enough amount of water. Enough means not very more, not more than 200 and not very less, but around 100 to 120 ml is good enough. Not with a plenty of water. That is very important thing. Second, patient has to wait for at least 30 minutes before eating, drinking or taking any other oral medication including thyroxine. Patient can take thyroxine after 10 to 15 minutes but not just after this medicine, because it requires at least 15 to 20 minutes to act, snack to act as a bioenhancer for semaglutide. Because it's a GLP-1 analog, the most common side effect is nausea, vomiting, abdominal fullness, which patient may or may not tolerate. That's why the criteria are, the plan to put this patient is to start with a lower dose, that is 3 milligram, that is the starting dose. Keep patient on that dose for at least around 1 month. If patient is fine tolerating, then shift to patient on a 7 milligram, and you may intensify with 14 milligram after another month, so patient can tolerate this drug for a with a better compliance. Otherwise, sometimes if you start directly with the higher dose, that I want to achieve patient with a more weight loss, so 7 milligram, 14 milligram, then initial side effect may be a limiting factor. And as far as missing the pill is concerned, if patient misses the pill on particular day, then patient has to skip the dose and take the medicine as per the routine schedule. Who are the ideal patient? Any patient, what we were talking about with insulin therapy, I am talking about type 2, I am not talking about insulin dependent diabetic patient. Any type 2 diabetic patient with insulin resistance who are uncontrolled on multiple OAD can be put as oral therapy. Even US guideline, ADA guidelines suggest that first injectable therapy in type 2 diabetes should be GLP-1 analog, and then they consider basal insulin as a second injectable therapy. But now, because we have available this GLP-1 as a peptide, you can try this in such type of patient. Patient who requires sugar control with a weight loss as a benefit. For SGLT2, I will suggest it will have a very good cardiac effect, but the weight loss is around 2.5 to 4 kg. With GLP-1, you can achieve 7, 8, 10 kg, even good responder, especially with semaglutide like molecule, 10, 15, 17 kg weight loss is possible. So whenever weight loss is in the mind, along with glycemic control, this is a best drug. Patient in whom hypoglycemia is concerned, still you can use this drug, even though it's a good HbA1c reducing drug. This is glucose sensing mechanism, so chances of hypoglycemia is very less. Patient who are already taking GLP-1 injectable and want to shift on oral, yes, that you can do. And patient with established CVD or high risk CV risk, injectable semaglutide is already having sustained 6 data, which is CV superior, but with oral semaglutide, at least at present, we have non-inferiority and CV safety data, so definitely you can put. As a molecule, it is renal and hepatic safe, so moderate renal dysfunction, mild to moderate renal dysfunction, or mild to moderate hepatic dysfunction you can use. But I will say, don't use any drug in severe dysfunction, especially ESRD patient, though it is found to be safe, but patient's appetite is not good at that particular time. Even in hepatic, the insulin is the best therapy at that particular time. And older patient, because older patient is a subset where we have to use any drug, or we have to add any drug into their already the drugs they are taking as prescription, that it should not be interfering with the other molecules, and it should be safe, and this is one of the found safe drug. As far as other extra glycemic effect is concerned, along with this multiple effect, this has shown cardiovascular benefit. Obesity is something which it targets very well, and actually no people are doing clinical studies using this semaglutide as an anti-obesity medicine rather than anti-diabetic medicine. That is excellent effect what they got. Chronic kidney disease, at present it can be used up to EGFR 15. We have data and it is found to be safe. It has some data on non-alcoholic steatohepatitis, and maybe we may have a futuristic drug for treating NFLD also, and this drug is been also considered for Alzheimer's disease treatment also because of its neurotropic effect on brain. It may be helpful to such type of patient also. Just to summarize my talk at the end, GLP-1 among the most effective medicine in type 2 diabetes management, which reduces HbA1c, which causes weight loss, which causes body composition change, and now we have drug which can reduce the pill burden also, and it's a scientific breakthrough that we have now the GLP-1 analog available as a pill with pioneer data suggestive of weight loss of around 5 kg with HbA1c reduction of 1 to 1.5%, which is far superior to SGLT2, DPP4 or any other routine OHA therapy. This may have an upper hand as far as overall treatment is concerned. Along with, you can add this drug to injectable therapy like insulin. If higher the HbA1c, you may get even better result. CV-SEPTA data is there, and we will have sole study result in next 2-3 years because it's an ongoing study with CV superiority data also. But use this drug early whenever is possible, especially whenever his patient is high risk or patient is obese, or when you want to achieve HbA1c control better, tighter with weight loss. Thank you.
Thank you very much, Dr. Piyush, for excellent and informative talk on semaglutide, which may change the scenario in future years in managing the diabetes. Session is open for any question.
If very oral is daily and injectable is weekly, why the TKPD is changed?
See, basically, injectable form, when they convert it into polypeptide, that molecule absorption is very less. It is only 1% which is getting absorbed. So, because this semaglutide molecule and bioavailability is too less, if you want sustained effect, it is not possible. See, I will say if injectable is available in India, I will still prefer injectable semaglutide because one thing, patient who are used to, who want fine with injectable once weekly, actually it increases compliance. First thing. And second, with oral semaglutide, because I was part of injectable semaglutide clinical study also, overall side effect profile was much lesser with injectable semaglutide in comparison to oral. That I think no people can answer, but I think that they don't have supply for injectable. That is one thing I don't know. No people. Yeah.
Yes, I agree with you, sir. Injectables should be available, but I think they are finding some business problem. They think that it's not viable in India at the price that they want to sell.
Yeah.
But I think from all of us, the message is that injectable semaglutide should be available before the tirzepatide, or how you pronounce it,
Tirzepatide
becomes available globally. It's already available in US now. Till now, none of the companies have succeeded.
Even Nova people are doing this for 12-13 years. Yes, for anti-obesity, for this pill, we have 25 and 50 milligram of semaglutide, and for injectable also it is higher dose. Instead of 0.5 and 1 milligram, it is 3 and 7. But yes, 3 milligram is just to start with. 3 milligram is, I was talking about injectable. 0.5 and 1 is the basic dose. For obesity, what they have tried was higher dose. That was 3.6 milligram they have tried. No,
What you want to bring down the A1C?
3 milligram will works like gliptin. It is just to start, because, and I will strongly suggest that whenever you start with 3 milligram, because even I have seen patients who were on dulaglutide and I have shifted them, they are also not it was causing more side effect. So it is always better to. Yeah, then you have to step up the therapy to maximum dose. And as far as price is concerned, it is not much different. So who can afford 3 milligram, they can afford 40.
Full study they are doing and it is totally injured. They are also doing a close study with injectable semi-renally compromised. Renally compromised injury. So,
Thank you, Dr. Piyush, and I request one of the practitioners to deliver the movement to the
Now this session is closed. Now I invite for next section chairperson sir Dr. B.K. Soni and Dr. Parag Rana.
I think it should be available within short period of time. It is approved in India also. And it's a very interesting and very novel way to improve the cardiorenal outcomes. We got lots of data with SGLT2 inhibitors. But we got a very interesting concept, that is a role of finerenone for cardiorenal outcome in patients with a CKD and type 2 diabetes. We all know that India has a huge burden of type 2 diabetes. And at the same time, we got a huge prevalence of diabetic kidney disease across the different type 2 diabetic populations and type 1 diabetic population. Around 48% of the patients in India with a type 2 diabetes has some evidence of the diabetic kidney disease. And despite good glycemic and blood pressure treatments achieving the goals, more than 30% of the patients still with type 2 diabetes would progress to the CKD. Though the natural history of CKD and type 2 diabetes do vary, patients eventually progress to either end stage kidney disease, or before they go for end stage kidney disease, many of the times they have a significant cardiovascular morbidity and the mortality. So if you compare the type 2 diabetes alone, if the patient is absolutely healthy, and what is the risk of the cardiovascular mortality is around 3.4%, where they don't have a diabetes or a kidney disease. If the patient has a type 2 diabetes alone, the risk of cardiovascular mortality is around 7%. If the patient has a only CKD because of some other cause, then mortality is around 10%. But if the unfortunate patient with the type 2 diabetes and CKD, the mortality is almost 6 times higher compared to the healthy individual. So that is around 20% of the populations would have a cardiovascular mortality. So if you see the interrelations between the cardiorenal profile, decreasing EGFR, increasing the cardiovascular mortality significantly, increasing urinary albumin creatinine ratio also would increase the cardiovascular mortality significantly. So as EGFR falls or albumin creatinine ratio increases, the cardiovascular mortality also significantly proportionately increases. So even in the USA, if you see the data from the US primary care practice data, even in the USA, CKD is not diagnosed in the medical records, even at the stage of CKD of stage 5, forget about CKD at stage 1. So that is the huge undiagnosed, unaddressed populations of CKD, even in the developed country like USA. So how actually the CKD progresses in type 2 diabetes? It is a combination of hemodynamic effects or the derangements, metabolic derangements, hemodynamically in the form of the elevated blood pressure or increase into the intraglomerular pressures, poor hypertension or the glycemic control. On top of that, there is a important pathophysiological reasons why diabetic kidney disease progresses, that is a inflammation and the fibrosis. If you have combination of all these three, what does it do? It leads to the tubulointestinal damage and inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and ultimately leading to the CKD progressions. And why actually and how the inflammation and fibrosis is a potential treatment target in the residual risk in diabetic kidney disease, like ACE inhibitor and ARBs predominantly, or the antihypertensive agents, and to a certain extent SGLT2 inhibitors through hemodynamics would improve the renal outcomes, while any oral anti-diabetic agents or injectable therapy, including SGLT2 inhibitor or a GLP-1 receptor agonist, by good glycemic control would reduce the chance of progression of the diabetic kidney disease. But there is a huge residual risk which is probably to be addressed, which takes care of the inflammation and the fibrosis. So there is no existing treatment primarily targeting the inflammation and the fibrosis which occurs into the diabetic kidney disease, which affects not only the progression of the diabetic kidney disease, but it significantly increases the cardiovascular morbidity and the mortality also. So if you see the landmark clinical trials like renal trial with a losartan, there is a good RAS blockade with a good relative risk reduction, but there is a huge, you can say, residual risk still is there. So that is predominantly having the hemodynamic effect. If you see two landmark clinical trials with SGLT2 inhibitors like Credence with the CANA and the DAPA CKD, on top the ACE inhibitor and ARB, if you add CANA or a DAPA, there is a huge significant reduction into the risk of deterioration of the kidney disease, but still there is a huge residual risk here as well as the here. So in spite of good hemodynamic and the metabolic control with the RAS blockade on top of the SGLT2 inhibitor, there is a huge residual risk which needs to be addressed. So what is the role of a MR or the mineralocortical receptor overactivation which causes kidney and cardiovascular damage through inflammation and the fibrosis? In kidney and the heart disease, the MR pathway becomes overactivated. There is an increased gene expression and pro-inflammatory cytokinase and pro-fibrotic mediators leading to inflammation and the fibrosis, which has a multiple pathophysiological effects on the kidney, vascular and the cardiac muscles. Like kidney, there is a glomerular damage, more proteinuria, tubular injury, reduction into the renal blood flow, endothelial dysfunction, increased vascular stiffness, myocardial hypertrophy, ventricular remodeling, reduced coronary blood flow, ischemia or infarction, and the myocardial injury. So MR overactivation is one of the important driver of a kidney damage because of the mineralocortical receptors regulate the gene expressions. In renal disease, there are multiple factors which overactivate the mineralocortical receptor, including aldosterone, cortisol, and others. Overactivation of MR signaling pathway drives the inflammation and fibrosis, and this results into deleterious effects not only on the kidney but on the heart, promoting cardiac remodeling and progression of both cardio-renal deterioration. So finerenone is a novel non-steroidal selective mineralocortical receptor antagonist which is bulky, it is a unique structure which results in most selective and potent interactions with the MR and regulations of the gene expressions, and through this it exhibits the anti-fibrotic and the anti-inflammatory effects. So what is the difference between finerenone and spironolactone eplerenone which are available with us? One and most important is the structure, which is a different. It is a greater selectivity and higher potency, and it is a equal distribution into the kidney and heart, unlike steroidal MRS that preferably distributed into the kidney. Greater reduction of the inflammatory and the fibrotic markers than the steroidal MRS. Less side effects like spironolactone, we all know in males leads to the gynecomastia, or it's a potential anti-androgenic effect which is not seen with the finerenone, and finerenone has a regulation of the MR gene expression which is not seen with the steroidal MRS. So finerenone now is approved in India in end-stage kidney disease, cardiovascular mortality, non-fatal MI, and hospitalization for heart failure. So we got an excellent clinical trial data in the form of the Fidelio DKD and Figaro DKD trials. So this is the very interesting studies like Fidelio DKD study where finerenone 10 mg or 20 mg was compared with the standard of care, and the primary outpoint was in the Fidelio DKD was basically the renal outcome trials, time to onset of the kidney failure, sustained decrease of eGFR of more than 40% from the baseline, or death due to kidney disease. Well, Figaro DKD is a primarily studied for the cardiac outcome, time to CV death, non-fatal MI, non-fatal stroke, and hospitalization for heart failure. And the secondary outcome trials for the Fidelio was cardiovascular, and for the Figaro it was the renal. And other endpoints was the all-cause mortality, all-cause hospitalization, and more than 57% decline of the eGFR from baseline over more than 4 weeks, or death due to kidney disease. So if you see the Fidelio DKD study design, type 2 diabetic, CKD, either albumin creatine ratio between 30 to 300 and eGFR between 25 to 60, and history of diabetic retinopathy, or more severe kidney disease in form of the USER of more than 300 and eGFR between 25 to 75, and treated with either AC inhibitor or ARB at a maximum tolerated dose, and potassium should be less than 4.8 at the time of the screening. Exclusion criteria: non-diabetic kidney disease, uncontrolled hypertension, NYHA 2 to 4, symptomatic heart failure patients, recent cardiovascular event, dialysis, or planning for a kidney transplant. So around 5,700 patients divided into finerenone 10 mg or 20 mg, and treatment duration was 44 to 48 months. And Figaro DKD was slightly less renal dysfunctions. CKD defined as a USER 30 to 300 and eGFR here was 25 to 90, or USER more than 300 and eGFR of more than 60, treated with the maximum tolerated dose of the AC inhibitor or ARB. Around 7,400 patients data, treatment duration of around 44 to 48 months. And if you see the major renal outcome trial data and you compare the number of population studied, like renal study with the losartan around 1,500 patients, IDNT study with the irbesartan around 1,700 patients, Credence with the Cana 4,400 patients, DEPA CKD around 4,300 patients, and the EPA kidney around 6,000 patients. While finerenone, if you combine Figaro and Fidelio, both are renally compromised patients. It is 5,700 plus 7,400. So huge populations studied with a significant kidney dysfunction to start with, and good cardiovascular and the renal outcome as a primary and secondary endpoints. If you see the trial duration is around 5.5 years, BMI is around 31, diabetes duration is around 15 years in both the study, well controlled hypertension, reasonably well controlled blood pressure and normal potassiums, and anti-hypertensive patients failing hypertension was around 97%, diabetic retinopathy around 46% and 30%, history of CVD around 45% is baseline in both the study, and heart failure around 7.5%. And if you see the EGFR in the Fidelio and the Figaro, here more than 60 around 11%, more than 60 around 61%, and 45 to 50 and less than 25 there was few patients. Albumin creatine ratio less than 30, 30 to 300 and more than 300. These are the baseline characteristics. And if you see the RAS blockade, around 99% of the patients were either on ACE inhibitor or ARBs in both the studies. Around 75% patients were on statin, and around 56% of the patients were on anti-platelet aggregation inhibitors and a different oral and injectable therapy. SGLT2 inhibitor exposure was around 4.5% in Fidelio, and Figaro was around 8.3%. So baseline characteristic summary, median follow-up was 2.6 years with Fidelio and 3.4 years with the Figaro. 98 and 99% of the patients were on maximally tolerated dose of ACE inhibitor or ARB, so they were adequately controlled for RAS blockade. And you can see baseline HbA1c also was reasonable, like with a baseline HbA1c of around 7.5%, so not poorly controlled. So both hemodynamically and the RAS blockade was good. Adherence to the treatment was high, 92% in the Finerenone and the placebo groups, so well tolerated as placebo. And cumulative treatment duration, number of permanent discontinuations also were similar between Finerenone and the placebo. So overall good adherence and similar permanent dropout patients when patients were on Finerenone or placebo therapy. Efficacy and safety outcomes. This is a Fidelio DKD study. Kidney failure sustained more than 40% decrease in eGFR from baseline, or the renal death around 18% relative risk reductions. Number needed to treat after 3 years is quite significant, 29 patients. Change in urinary albumin creatine ratio, you can see within 4 months there is a significant drop in the USER, which is maintained for the study durations. And secondary kidney composite outpoint, where more than 57% decline in the eGFR was significantly less in the Finerenone study. Fidelio Finerenone significantly reduced the risk of the secondary cardiovascular endpoint by 14% versus placebo, with a number needed to treat was 42. So significant cardiovascular benefit also. In the Figaro, which was a primarily cardiovascular outcome as a primary endpoint, around 13% relative risk reduction for the cardiovascular mortality, non-fatal MI, non-fatal stroke, and hospitalization for heart failure. What about the hyperkalemia? Out of around 2,800 patients, around 64% patients led to the permanent discontinuation because of the hyperkalemia, which was a very small number. So it is safety and the vital signs. Finerenone had a modest effect on the blood pressure, around 3 to 4 millimeter reduction into the systolic blood pressure. HbA1c levels and the body weights were similar. There was no difference in acute kidney injury between the Finerenone and the placebo arm. Sexual side effect, there was gynecomastia was rare, and it was same in the Finerenone and the standard of care. So well tolerated. Overall incidence of treatment emergent adverse reactions were similar. Mean increase into the serum potassium was around 0.2. All the permanent hyperkalemia was increased by temporarily withdrawing the Finerenone. It was manageable. The clinical impact of hyperkalemia was minimum. If you combine the data of Fidelio and the Figaro DKD, you have around 13,000 patient data of cardiovascular and the renal outcome with this eGFR and the urinary albumin creatine ratio. You can see Fidelity, which is combination of the both the study together. Cardiovascular key composite endpoint relative risk reduction was 14%. Hospitalization for heart failure was reduced by 22%. Non-fatal MI, non-fatal stroke also was significantly reduced. And similarly for the kidney outcome trial, more than 57% kidney composite endpoint in the form of the 57% reduction into the eGFR was seen in around 23% relative risk reduction of this. If you have the some subgroup analysis of SGLT2 use on top of them, if you give the Finerenone, there is a significant reduction into the urinary albumin creatine ratio, though the usage of SGLT2 inhibitor was around 4.5% only. So if you summarize both the study data, it significantly reduces the cardiovascular mortality and morbidity and significantly reduces the deterioration of the renal dysfunction. So if you see the ADA 2022 guidelines, it says that in patients with chronic kidney disease who are at increased risk for cardiovascular event or chronic kidney disease progressions, or who are unable to use the SGLT2 inhibitor, Finerenone is recommended to reduce the chronic kidney disease progression and the cardiovascular events. Level of evidence grade A. So how to use it actually? Two things you have to measure prior to starting this therapy. One is the serum potassium and second is the eGFR. If the eGFR is more than 60 and potassium is 5 or less, you can start with this drug. eGFR more than 60, you can straight away start with 20 mg. eGFR between 25 to 60, 10 mg. Less than 25, not recommended because there is no study data of eGFR of less than 25. After starting the medications, you repeat the potassium after 4 weeks. If the potassium is less than 4.8, if patient is on 10 mg once a day, you increase the dose to 20 mg once a day. If patient is 20 mg and potassium is less than 4.8, you maintain 20 mg once a day. If on 10 mg, potassium is 4.8 to 5.5, you can maintain the 10 mg. If the patient is on 20 mg, up to 5.5, you can continue with the 20 mg. More than 5.5, patient on 10 mg, you temporarily withhold the Finerenone, repeat after 4 weeks, and if the potassium is less than 5, you may restart, and if the patient has a repeat increase in the potassium more than 5.5, then you may consider permanently not restarting it again. Same with the 20 mg, but then you start with the 10 mg if the patient's potassium has gone more than 5.5. Of course, you have to take into consideration what was the reason of hyperkalemia other than starting Finerenone therapy. Contraindications: certain drugs which has a strong CYP3/4A inhibitors like rifampicin, carbamazepine, phenytoin, you should be very careful, or you should not be using. With adrenal insufficiency where there is no mineralocorticoid activity, it is of no use to be given this. So key point, MR overactivation is one of the major driver of the kidney damage. MR overactivation, which contributes to inflammation and fibrosis. It has potential treatment target to slow the CKD progression. Finerenone selectively blocks the MRA. Overactivation reduces albuminuria. It is different from the available steroidal MRAs. It is studied and showed a potential benefit to slow the CKD progression and prevent the cardiovascular events by directly targeting the inflammation and the fibrosis. Fidelio DKD and Figaro DKD results indicate that the Finerenone is an effective treatment option for cardiovascular and the kidney protection in patients with a CKD stage 1, 2, 4 and type 2 diabetes. Thank you very much for your patience hearing.
This molecule is likely to become one of the important medicine in our armamentarium for type 2 diabetes with CKD. Can I request Dr. Parishit to come?
In combination, why not both? See, if you see the data on top of the SGLT2 inhibitors, still there is a huge residual risk. So, if the patient's already on SGLT2 inhibitor, you want to add something where you want a good cardiorenal protection. On top of the SGLT2 inhibitors, also RAS blockade also, you can add this molecule, not in place of that. Whenever there is a role of SGLT2 inhibitor, you can always have the SGLT2 inhibitors, and SGLT2 inhibitor does not lead to the electrolyte disturbances. So you can start both at the same time, or patient already on SGLT2 inhibitor, you can subsequently add this on top of the RAS blockade and top of the SGLT2 inhibitors also. Usually all clinical trials, unless patient is hemodynamically stable, they exclude the patients. Like all the clinical trials what we do, usually 3 months is the usual time where they want to exclude the patient, because mortality, morbidity, hemodynamically, patients are very unstable. So all major clinical trial, unless it's a very bold trial where acute coronary event and you want to do something, then it's different. Like ARNI, there are some studies with the after acute myocardial infarction, you can give heart failure patients. Otherwise, in all the usual clinical trials, they exclude the patient with the recent coronary events for at least 3 months. Not much. Yeah, that is true for all actually. No, you should not be using.
To be started SGLT2 inhibitors and then Phenynon?
See, this does not have an effect on the blood pressure much. So you can start both at the same time also.
No, without SGLT we can
start. Yeah, you can start. You can start. It will depend upon the EGFR actually. If the EGFR is good, you can start straight with the 20 mg. More than 60, 25 to 60, you start with the 10 mg and follow with the EGFR and the potassium.
There are no questions. Can we request the chairperson to felicitate Dr. Saraj? Thank you, Dr.
So our next speaker is Dr. Navneet Shah. He's a very good teacher and he taught generations like me. And he needs no introduction. At present, he is a practicing diabetes and endocrinology since 1985. And he has been like stalwart in our
So I would like to invite Dr. Navneet Shah for his next talk. Do Indian dyslipidemic patient need special attention?
Good afternoon, and let me begin my talk with thanking the RSSDI Gujarat chapter, Dr. Bansi, Dr. Ulmandru, Dr. Pratap and Dr. Sandeep Desai, and each one who have helped in organizing this conference. I also thank Dr. Chintan and Dr. Parag for their kind words. And today my talk is whether Indian dyslipidemic patient needs special attention or not. We all know that our dyslipidemia is very peculiar, and we are all characterized by low HDL, high triglyceride. Whether we are diabetic or we are not diabetic, that is the hallmark of Indian dyslipidemia. And this could be a part of metabolic syndrome and other things which also we should know. So let me begin with one important thing, that we often use the term high intensity statins. And what is high intensity statin? A statin which has got the reduction of LDL level at baseline to 50% is high intensity statin. So remember that. So there are only two statins which are like that. One is atorvastatin and the other one is rosuvastatin. Then you have moderate intensity where you can have 30 to 50% LDL reduction, and when the LDL reduction is less than 30%, then low intensity statins are there. Then
statins are used as a primary prevention or as a secondary prevention of cardiovascular problems. And here are, sorry, this slide is not very clearly visible, but there are some trials which have proved to be of value in secondary prevention of statins, namely post-CABG reversal and other PROVT, TIMI, A2Z, TNT, and etc. So they have shown the secondary. But if you look at this cartoon slide, then there are statins which have been associated with secondary prevention, and there are a number of studies. And lower the LDL, the better are the result. And same thing about the primary prevention. And most important is, you look at here the Jupiter trial, Jupiter rosuvastatin 20 trial, which has a very remarkable effect of LDL reduction and the benefits related to events rate in the statins. So, challenge of cardiovascular disease in India is known to you. We know that leading cause of death in India by 28.1% of cardiovascular disease, and in India 50% of the cardiovascular disease mortality occurring in individuals less than 50 years are 50%. So that's a significant number of cardiovascular problems in India in even at a younger population. So characteristics of, we know that thin fat Indians, like risk of CVD is higher in Indian patient, and we are a decade earlier than the Caucasians and the Europeans. Our 10% of the heart attacks occur in Indians of less than 40 years, and it must be all of your experience that we may see even MI at the age of 20 or 25, 30, and that is a reality. And 52% of the CVD deaths occurring under the age of 70% are because of cardiovascular disease. And Dr. Yusuf also showed that in inter-heart study, where 9 important factors were associated with myocardial infarction, dyslipidemia was one of the strongest contributor to the myocardial infarction. So here is a patient who is male, 42, normal blood pressure with history of diabetes, and his current lipid profile is around slightly elevated LDL, HDL is almost normal or low normal, triglyceride is also elevated, and then he was recommended lifestyle changes, and after 6 months also there is probably hardly any significant change in the lipid profiles, and he was not prescribed medicine at that point of time. So these are the patients. Initially when we were educated in our earlier days, then usually statins were the drugs of the middle age or the old age people, but now the crucial point is that at what age we can start statin. That is also an important thing. So here it is a poll question, but we'll forget it and then we'll go further. There is a study which was published in 2015, and it showed that 1 millimole reduction of LDL reduced 21% risk of major vascular event, which you can see on the right side of these slides. And you have also, with this kind of reduction in LDL, there is a 24% reduction in major coronary events, 24% reduction in coronary revascularization, stroke is reduced by 15%, any vascular death is reduced by 12%, and any death is reduced by 9% in addition to the major vascular event. And you know, 1% reduction in LDL will reduce the risk of coronary artery disease by 1%. But if you increase 1% of HDL, you will have the reduction of death or myocardial infarction by 3%. So that is a very significant and sizable number of the effects of reduction of LDL and increasing HDL. And this slide also shows that meta-analysis of 8 statin trials where the risk of major CV event, patients who were risk of major CV event was directly proportionate to the number of LDL cholesterol, whether it is cardiovascular events, major coronary events, or major cerebrovascular event. And lower the LDL, lesser number of patients are at the risk of cardiovascular events. So you can see here from more than 175 LDL to less than 50 LDL, From 32.8%, it comes down to 4.4% CV risk because of the LDL reduction. So what guidelines suggest? Now we had started with ATP1, then 2, 3, AHA, ACC, but ultimately the latest, as in diabetes management, we have seen that ACE guidelines and other guidelines like ESC guidelines, the patients who are at very high risk, their LDL should be less than 55, and those who are at high risk, their LDL should be less than 70. So that is a very important change which we must impregnate in our mind, that LDL reduction is not 100, not 80, but very high risk patient we have 55. Number of times happens that patient comes to you with very low LDL and says that doctor, do I need to take these drugs now because my cholesterol has become normal. So don't think cholesterol is a number game. The benefits of statins are beyond the number of LDL. So if patient is comfortable even with the LDL of 40 milligram per deciliter, please continue statin if he doesn't have any ill effects associated with this reduction. So number of times many of our patients, they have low LDL, they are asymptomatic, please continue and don't do. So don't believe in alternate day statin therapy or 5 milligram statin therapy, because these are the drugs which are very highly effective, pleiotropic, and they have a sizable benefits in coronary artery disease prevention, either primary or secondary. So remember this thing, this is a very important message. And if you look at the treatment goals for LDL management, this is the ESC 2019 guidelines, where it started from low score. Score is a system from the Europeans which will give you the idea of coronary artery disease in comparison to ASCVD, which is an American system. You can see here whether you follow the score or whether you follow the ASCVD. But if you have very high risk, whether ASCVD, clinical or imaging, and score, the LDL goal is 55 milligram or 1.4 millimole per liter, and that is very important thing. You can find out the subcategorization of this risk from 1% to 1 to 5 and 5 to 10 and like that, and from there your LDL goal would be different according to the risk stratification. So what are the common message in both ESC and ACC? That identify LDL-C as a primary target of therapy. So when you look at the lipid profile, many patients would come with only serum cholesterol. Don't do that. Ask them to do whole lipid profile, look at LDL, and lower LDL is better than with the proven pharmacotherapy and better lifestyle habit. Both emphasize 50% or more lowering of LDL cholesterol, and each set of guidelines addressing the primary prevention population is the estimation of cardiovascular risk through accepted risk scoring system. As I mentioned, European is SCORE, systemic coronary risk evaluation, which depends upon two things: systolic blood pressure and the ratio of total cholesterol divided by HDL, and the ACC-AHA arteriosclerotic cardiovascular disease, or popularly known as ASCVD risk evaluation. And the goal is 50% LDL reduction, or if very high risk, 55 milligram of LDL cholesterol. This is a calculator which you must have seen available in Medscape and the Medcare and other things, and all of you should know about the ASCVD risk, and from there you can find out the current 10-year ASCVD risk, and based on that you can think of whether this patient would need a statin therapy or not. So here is the ACC guidelines recommended goal of 50% LDL reduction for optimal ASCVD reduction. So you look at the LDL cholesterol, your risk is the ASCVD risk factors, you look at the age. If patients who are having lipid abnormality, which is because of the familial hypercholesterolemia, even below the age of 19 would need statin therapy. So don't think that statins are the drugs for only middle-aged or old people, but it can be given to younger people also. Those patients who are above the age of 20 and they have a estimated lifetime risk which is significant, and then there are if ASCVD risk enhancers like family history, chronic kidney disease, metabolic syndrome and other things, then these patients would need a statin therapy irrespective of the number of age. That would be important. And here if you look at this, if your ASCVD risk is more than 20% and then you need a drug which will reduce LDL cholesterol by 50%, and that should be the optimum risk reduction for the goal of lipid management. And here the events rate, which you can see here, that if you reduce LDL by more than 50%, your event rate goes very low to the level of 4.8 per 1000 persons, and that is a significant change in the LDL event. If you reduce LDL by 50%, then the benefit is required to number to treat patient is only 26 number needed to treat the patient. And if you aim at only LDL reduction to the 20%, then you need 63 numbers to treat the lipid abnormality to get the benefit. So that is also important. For our patients, ESC guidelines recommend adding drug if uncontrolled on lifestyle modification, and then there are risks and there are LDL levels, and from that you can find out that LDL level is high and the risk is high. You need to put them on statins depending upon the stage of the therapy. So what are the class A indications? That recommendation for pharmacological low intensity lipoprotein cholesterol lowering is recommended to prescribe to a high intensity statin up to the highest tolerated dose to reach the goals set by specific level of risk, and that is a class 1 recommendation and level A recommendation. If the goals are not achieved with the maximum tolerated dose of statin of high intensity, the combination is recommended with the ezetimibe. And then if the combination and statin, if they are not working, then there is still further recommendation is that PCSK9 inhibitors can be given to this group of patients. We have yet to use the newer drug, and we do not know whether that may be in between the statin, ezetimibe and PCSK9 inhibitor, that is a bempoic acid, and that time will tell us. So now we know that these are the characteristics of various statins, and you can see that rosuvastatin is a very wonderful molecule, hydrophilic, its clearance is by liver and kidneys, half-life is 20 hours, and effect of food on bioavailability is 0. So that drug can be given at bedtime to the any time in the day, and that works beautifully. The same another drug which has a very half-life is pitavastatin, which has got a half-life of 11 hours. The most of the drugs except the rosuvastatin and pitavastatin, they are affected by the food, their bioavailability goes down, and we can see that there is a issues regarding those things. Then we also have CYP 450 limited and CYP 2C9/8 limited metabolism, that also we should keep it in mind for various drug interaction. So Jupiter trial showed that it is a trial which was used with almost normal LDL levels and a high CRP. It showed that by LDL reduction of 50% between the group difference from baseline to 12 months, and then there was an increase of HDL by 4%, there was a reduction of triglyceride by 17%, and HSCRP was reduced by 37%, and these change in parameters helped in treatment by CVD reduction by almost 44%. So this was the primary endpoint which was shown in Jupiter trial, and the number of patients were more than 8,900. If you look at the risk of fatal or non-fatal myocardial infarction, which was reduced by rosuvastatin 20 mg by 54%, and total mortality was reduced by 20% in this trial. So that is a very significant number. And if you look at the risk of fatal or non-fatal myocardial infarction reduced by 54%, risk of myocardial infarction, stroke and cardiovascular death was reduced by minus 47%, and risk of fatal or non-fatal stroke was reduced by 48%. So this is a very important thing. Now there is a slide regarding the whether we should go for the generics or whether we should go for the innovator brand. So when we have a generic brand, there could be an issue with the side effects, an issue with the reduction of drug efficacy, which can be seen here. And then there are some trials of atorvastatin, generic atorvastatin, that also showed that the methylated atorvastatin impurity was highly observed in generic atorvastatin, which was associated with decreased efficacy and increased side effects. And the trial showed that CV events were more common with generics than the original innovator brand, and that is also we should keep in mind. So many times what happens, patients come to you and they would ask you whether I should use a original brand or a generic brand. Then you can give them the example that these are the things, but we cannot dictate them. Then no, you take this brand also. And likewise in rosuvastatin also, the stability of innovator research rosuvastatin formulation is excellent, but it may have impurity in form of lactone, anti-isomer and 5-keto acid. These impurities can be formed during or after production of the rosuvastatin tablet, can impact the stability of rosuvastatin formulation and overall shelf life, and that can also be associated with reduced efficacy and increased side effects in this thing. So take home message is that dyslipidemia is a major risk factor for cardiovascular disease. Risk of CVD is higher in Indian patients, as we mentioned earlier. The lower is better, the lower LDL levels are better for risk reduction. Guidelines recommend setting of LDL goals for the patient for primary prevention and use of statin as a first line of therapy, and for to reach the goal set by a specific level of risk. Rosuvastatin helps reduce LDL reduction by 50% and risk of CV death by 44%, and to have optimum efficacy we can consider original statin in form of rosuvastatin. So friends, what is important is that when we use, look at your pathological report. Most of the times they would recommend some ATP3 guidelines or something. Tell them that you change this, the things are different. So patients should not have the misconception of the normal values of statin levels, and then we can guide them for an optimum LDL reduction. Once LDL is controlled, then look at the other things like HDL or triglyceride or non-HDL cholesterol, and then try to fix the other things also. If you think that these lipid abnormalities are not that bad, but even then you need to have 50% reduction of LDL for optimum effect, and that is why you must use a high dose statin therapy, as I mentioned earlier, rather than using a half-hearted dose of statin for the management of lipid profile. So friends, thank you very much. And one thing which is very important, that when we talk about statin, I often do not look at even lipid profile in diabetic population and give them statins. Once I give them statin, most of the times it has been mentioned very clearly that you will need this statin for lifelong, and if you have low levels of cholesterol and if you are not symptomatic, please don't worry about that. Continue your statin therapy, which is going to help you. Thank you very much.
Mild renal insufficiency, we change from rosu to atorvastatin.
How much dose you are using, it depends on what are the other drugs, but usually atorvastatin is more preferred than the rosuvastatin in renal impairment. But I think if I am giving them 10 milligrams of rosuvastatin, I continue.
And that goal basically, suppose we have a patient who has a highly complex disease and we need to have a goal of suppose 55, and the baseline say LDL is 120. So depending on the baseline LDL, do we need to start with a combination therapy at the word go, or start with statin, rosuvastatin, and then see the LDL, and then, because the newer guidelines recommend combination therapy.
No,
No, that is true.
depending on
But if you
the
look at
extent of reduction.
No, the first thing is that your goal, whether the 50% reduction or the 55, depending upon the risk stratification, whichever is lower, that is one goal. Second goal is that you use the maximum tolerated dose of statin. If it is not tolerated and you still need to have something better than the result, then add ezetimibe.
So actually the newer guidelines of the ESC and all, they recommend that you will not achieve a particular amount of reduction with statin, even with the maximum. Then from the word go, you have to use statin with ezetimibe or statin with PCKS. That is a newer recommendation of combination
Now
therapy.
look, PCKS is difficult because it is an injectable and costly therapy. So where do we advocate PCSK9 inhibitor is that patients who are maximum tolerated dose of statin on ezetimibe, and despite that good control of cholesterol to the level of 55 or something, still they have an event on therapy, then they would be an indication for PCSK9 inhibitors. We still do not have used the campoic acid right now to the extent that we can think of that thing. So, yeah, we can use it. There is no harm in using it. Many times what happens that when we want to use, thinking that this patient would need 40 milligrams rosuvastatin, we can get 20 rosuvastatin, and the combination with 20 and 20 is available. So we can use that also. So it's perfectly all right. There is no harm in doing that.
Sir, primary goal is LDL. After controlling LDL, if triglyceride is very high, remaining persistently
if your
high.
LDL control is there and still the triglyceride are high, more than 200, and sometimes even if you have more than 500. If you have more than 500, it is a different strategy management that you go for diet and other things, and if alcohol is there or anything, you find out the ways for that. But if it is still high, then whether you are using the statin, which is like rosuvastatin, which has got an effect on triglyceride rather than atorvastatin. So any time you look at the lipid abnormalities, and if you think that the cholesterol LDL is abnormal, HDL is low, and triglyceride is high, that patient would be an indication for rosuvastatin. So don't think that that would be an indication of atorvastatin. First thing. But even then, afterwards, you have couple of options available now that you can use of saraglitazar. You can still use the omega-3 fatty acids. We are not using niacin nowadays for triglyceride. And then modification of diet would be also important. So these are the things which we usually recommend it. And except when you see very high level of triglyceride and it is not familial hypertriglyceridemia, then these patients would respond to a diet therapy very well, even with a small amount of the drugs targeting the triglyceride.
Should we add fibrates or not?
Fibrates we can add, provided patient's renal function is fair. If you are going to monitor the renal functions better, and which fibrate you are using, whether you are using fenofibrate or whether you are using choline fenofibrate, depends upon that. So if you look at the fibrates and if you compare with the choline fenofibrate, then choline fenofibrate is little safer, more tolerated, and can be given, and more renal friendly in comparison to fenofibrate. Beg your pardon? Omega-3 fatty acid will be used whenever possible, but I am not aware of the purified omega-3 fatty acid. Purified DP. I am not aware of it. And cardiovascular benefit. Right.
Sir, last question. Statins and diabetes. Do they raise the risk of new onset diabetes? And if yes, then in pre-diabetes, which statin?
Now,
to be very honest with you, there are people and there are doctors who think that if there is a family history of diabetes, don't use rosuvastatin, use atorvastatin. But you know, you look at the lipid abnormalities and how high intensity statin you need to use, and then all statin guidelines, the risk of diabetes versus the benefit of statins in the lipid abnormality. If you compare both, the statins are preferred, and no, there is nowhere it is contraindicated to patients who are predisposed to develop diabetes or a family history of diabetes. So I think in my practice, I personally do not see that point very important, and I may use rosuvastatin even then. If the abnormality which is in form of low HDL, high triglyceride, I would still prefer a rosuvastatin rather than atorvastatin.
Sir, in your practice, when you are using 20 milligram, 40 milligram rosuvastatin, what is the incidence of myalgia and weakness?
Honestly, I have the amount of statin I have used, I have not used 40 milligram. If I use 20, I usually need more than I would add ezetimibe instead of using 40 milligram. But no patient has been withdrawn because of the myalgia or myositis or CPK or anything, nothing. I'm all comfortable with using statin.
Because we are using atorvastatin up to 80 milligram in medical colleges, but hardly we found any weakness or myalgia. So
Atorva 18 usually we use in acute coronary events.
Yes.
And then most of the time after 6 weeks or 2 months we'll come down to 40 milligram atorvastatin.
Thanks.
Are getting statin for hypertension. Once already diabetes developed and you have started statin, then there is further hypertension.
No. And to be very honest, if you are having a patient who is pre-diabetes and his risk for coronary artery disease, you assess and then you look at the use of statins, because that is a very vital point. We look at the ASCVD or the score system and find out that what is the risk of coronary artery disease. So that is a very important thing. And Interheart say it very clearly that if you address dyslipidemia, you would be benefited most in comparison to all other 8 risk factors.
Thank you very much, sir, for your enlightened journey into cholesterol management. I would like ask Dr. Parag Rana to give a moment of appreciation to our base teacher, Navneet Bhai. Now I would like to invite Dr. Pratap Chethwani for his talk on early basal strategy in type 2 diabetes and how beneficial it is. First of all, we all would like to clap and appreciate his effort as a RSSDI putting up all this event post-corona, and he has been tremendous force to get this conference on table. So I would like to have him the mic and start the.
Thank you, Chintan. So let me thank all of you, all the faculties, all the chairpersons, all the delegates for joining in our battle against diabetes and supporting our every event. And we expect your support in our future Gujarat chapter events also. So today I will be speaking on early basal strategy in type 2 diabetes, how beneficial it is, and it is a sponsored talk by Sanofi, and this is the agenda of my talk. I will start with why we require timely insulin initiation. We all know that type 2 diabetes is a progressive disorder, and at the diagnosis only more than 50% of beta cells, they are exhausted, they are dysfunctional, and this will keep on progressing, and ultimately there will be a irreversible insulin insufficiency, and many of patients, they will require insulin therapy. This is the UKPDS data which says that progressive decline of beta cell function that will result in deterioration of glycemic control, and we require to keep on adding more and more therapies, and ultimately the patient will need insulin for better glycemic control.
We also know from VADT that we need to be aggressive early enough, because in long-standing diabetes with multiple complications, multiple comorbidities, if we try to be aggressive, then that will not translate into reduction in complications, that will increase the risk of hypoglycemia, and that may be detrimental. So we need to be aggressive early enough so that we control glucose very effectively without increasing the risk of hypoglycemia and giving our patients long life free of complications. Early insulin therapy, there is data to support that it has got impact on beta cell mass and function. It slows loss of beta cell mass and function, and it aids in providing long-term efficacy against the complications of type 2 diabetes. And we all know from UKPDS that if you reduce HbA1c by 1%, that will translate into a variety of benefits. Deaths will be reduced by 21%, myocardial infarction down by 14%, and mainly microvascular complications will go down by almost 37%. We all agree that timely insulin initiation is very much important, but we have got a lot of barriers to insulin therapy in our clinical practice, and this is one of the main reasons of clinical inertia in the management of type 2 diabetes. There is fear of hypoglycemia, there is fear of weight gain, lack of flexibility, injectable therapy, and even healthcare professionals, they are reluctant to start insulin because they have to spare time to explain patient about why they need insulin, what time they need to take insulin injection, then insulin injection technique, insulin storage, site rotation, hypoglycemia symptoms and management monitoring. So that will take around 25-30 minutes of a busy practitioner who is seeing 100 patients in a day. They will not find it difficult to convince patients or spare that much time to counsel them about insulin therapy, and that is one of the biggest inertia reasons for reluctance by HCPs to start insulin in a timely manner in our type 2 diabetic patients. Patient barriers, we all know that most of the people, we were yesterday also talking that allopathic medicines including insulin, they do more harm than good, and they will give you an example that my relative was put on insulin and then kidney failure occurred. So all these things, they occur. There are lot many myths in general public about insulin therapy, and I think we at RSSDI need to address this concern by doing more public awareness programs and community awareness as far as diabetes management, role of allopathic medicines including insulin in diabetes management is concerned. People, they feel that it is very difficult to integrate insulin in their daily life, and that is very true with premix insulin therapy. Sometimes titration algorithms are very complex, very difficult to follow in routine clinical practice. And most of the people, they feel that insulin, that means I have reached the end of diabetes and then now I am going to land in the complication. So insulin therapy is also a very big factor for distress for type 2 diabetic patients. Hypoglycemia is a very important concern by healthcare professionals, and we all agree that be it primary care physicians or specialists, diabetologists or endocrinologists, all they feel that if we have got insulin, it does not increase the risk of hypoglycemia, everyone will start their patients on insulin therapy. So we need to have a steps whenever we want to put our patient on insulin. We need to have an insulin conversation, and there are 5 steps. First, we need to discover how patient feels about insulin and then address their fears and concerns about insulin therapy, about hypoglycemia, and about various other aspects of insulin therapy. We need to educate our patients, and for that purpose we can train our staff. They can easily educate patient about insulin injection technique, monitoring, hypoglycemia symptoms and management. So you need not to spare 20-30 minutes. You can counsel your patients and then you can re-educate them about all the things. Problem solve with the patient. Specific problems, they require specific solutions. You need to individualize that. You need to develop a plan together with the patient, that what is our target and how we will reach that target by starting the insulin therapy, and then you set the goals and the expectations. In this way, you will be able to convince your patients to start insulin in a timely manner. Now, how can we use basal insulin? How to address all the barriers which I have highlighted here in timely insulin initiation. We all agree that there is enough evidence to say that type 2 diabetic patients where you want to initiate insulin, then basal insulin is the choice of therapy. Most of international guidelines and national guidelines today, they recommend basal insulin to be started in type 2 diabetic patients where you need to initiate insulin therapy. Previously, it was either premix or basal, but since last 5-6 years, the focus has shifted to basal insulin only because it is simple to start, very simple to titrate, very simple to monitor, and easy to follow in clinical practice. And it has got definite evidence to support that it is having same efficacy and better safety as compared to premix insulin. So ADA says that basal only regime is the most convenient initial insulin regime. Be Smart approach also tells same, and it says that it reduces long-term complications and improvement in outcomes, and this is the way the patient will continue with oral therapies, same meal plan, everything will be there, and you have to just add one prick of basal insulin. So it fits very well into daily schedule of patient, and that is the way you have to start insulin therapy in type 2 diabetes. Even in COVID era, the poorly controlled type 2 diabetes patients, this JAMA article which says that basal insulin is to be preferred whenever you are thinking of insulin therapy in these patients. We all know that basal insulin is less complicated, whereas premix is more complex. Higher dose is required, more chances of hypoglycemia, more chances of weight gain, and you need to adhere to a very strict lifestyle, meal timings and everything you have to follow. So it is a bit complex as compared to very easy way to start basal insulin. There is lot of evidence to support that basal analog is much better than premix human insulin, premix analogs, and even co-formulation as far as hypoglycemia or weight gain is concerned. This is one study where 28-week they have tried to find out premix insulin analog as compared to insulin glargine 100 unit, and there was a less number of hypoglycemia in glargine 100 as compared to premix human insulin analog. Same way, if you use a co-formulation, the overall daytime hypoglycemia will be reduced when you use glargine as compared to co-formulation. But at the same time, in most of these patients, when you try to reach that target fasting plasma glucose of less than 100, there is a bit increased risk of nocturnal hypoglycemia with glargine 100 as compared to co-formulation. And this hypoglycemia will result in snacking, that will result in weight gain, and that is evident from the studies. Whether you use premix analog, it will result in more weight gain as compared to glargine 100, and the same way co-formulation, it is associated with a bit more weight gain as compared to insulin glargine 100. And because of this, a simple way and very much safety and efficacy, the treatment adherence is better with insulin glargine, basal insulin analog as compared to premix analogs or co-formulation. And this is real world data where it suggests that more people on basal insulin, they adhere to therapy at the end of 6 months as compared to premix insulin. There is also data, small data set available that where patients who were uncontrolled on premix insulin and then they were shifted to optimal dose of oral anti-diabetic agents along with glargine 100, although the number of people are only 70, there was a reduction in HbA1c, fasting, postprandial without much increasing the risk of hypoglycemia and providing better treatment in satisfaction to the patients. 44% more adherence with once daily regime as compared to twice daily regime. We all agree with that. And less monitoring is required, particularly in COVID era when you want to have a less interaction with patient. I think this is the insulin where less monitoring is required. Healthcare professionals will not be exposed to much risk when they are exposed to this COVID kind of patients. You can easily shift from NPH or once daily premix or twice daily NPH or twice daily premix to once daily basal analog, that is insulin glargine 100. When you are shifting from once daily, the same dose is required. But if you are shifting from twice daily NPH or twice daily premix, then 80% of total daily insulin dose is required in case of NPH. And in case of premix, you have to calculate the NPH dose and give 80% of that total daily dose. Another important advantage of basal insulin is whenever you want to intensify therapy, in premix insulin you will not be able to intensify therapy. You are giving twice daily premix insulin, then you have to either shift them to a basal insulin with GLP-1 or you have to shift them to a basal bolus therapy. But in case of basal insulin, you have got all the options. You can shift them to a twice daily premix insulin, you can shift them to a single prick of co-formulation. You can add only one prick of bolus insulin, that is basal plus, and then gradually advance on to basal bolus therapy, and even you can utilize GLP-1 analogs on the top of basal insulin therapy. So all kind of intensification you can do with basal insulin therapy without changing the baseline insulin therapy. You can add on another agent and that will provide you better physiological insulin replacement and better glycemic control. So to finally say, the advantages of basal analogs in COVID-19 pandemic is simple and convenient to initiate, very easy and very safer to titrate, smoother maintenance period following active titration phase, very effective in clinical practice. Definitely there is less glycemic variability, more amount of time in range, less hypoglycemia, less weight gain, very easy to monitor, flexibility of adding oral on top of that therapy, improves patient satisfaction, improves adherence, and also reduces the exposure, particularly in the era of COVID-19 pandemic. I will just touch upon the glargine generation 2 basal insulin, that is glargine 300 as compared to glargine 100. We all know that this is a technological advancement which has occurred, and when they have made this glargine 300, it has become a much flatter action profile as compared to glargine 100, which has got a peak at around 4 to 8 hours. Because of the smaller volume of injection, more compact subcutaneous depot with smaller surface area, more gradual and slower release from the depot surface, there will be a change in PK/PD of the glargine insulin, and that will translate into a much flatter profile, and the glycemic variability will reduce from 28 mg per dl with glargine 100 to 50%, that is 14 mg per dl with glargine 300. So lesser fluctuation, better time in range will be there if you use glargine 300 as compared to glargine 100. And glargine 300 is available in a pen, in a cartridge or a pen of 450 units, so that is almost 1.5 times the routine cartridge that contains glargine 100. So it is also going to be cost effective, because the amount, the per unit cost of insulin, if you use glargine 300 or glargine 100, that is not much difference. So it is going to be a cost effective way of initiating insulin therapy, particularly in people who are at high risk of hypoglycemia. There will be less hypoglycemia, particularly nocturnal hypoglycemia, which is the problem with glargine 100 when you use it in high amounts, and overall hypoglycemia is also reduced in type 2 diabetic patients. It definitely shows lesser nocturnal glycemic variability as compared to glargine 100. I have already highlighted 2-fold decrease in within night glycemic variability, and nocturnal GB between night was numerically lower with glargine 300 as compared to glargine 100. And better time in range profiles when you use glargine 300 and you add one prick of glycine, that is basal plus, then it gives you a better time in range as compared to IDEC-ASP, that is co-formulation. And the one disadvantage of co-formulation, that it is in a fixed combination, so you cannot modify the dose of one component. When you change the dose of co-formulation, if you increase, then both the components will increase, the basal component as well as the bolus component. Whereas in basal plus, you can change the dose depending on the profile, either of them you can adjust depending on the glucose profile of the patient. So it is very easy and safe to start with Glargine 300, and at the same time it is very easy and safe to titrate with Glargine 300. Various algorithms are available, that is 1 unit every day. Generally in our practice we follow 2 units every 3 to 4 days and then reach the target of fasting plasma glucose of 100 or 110, and then you can decide about the further therapy. So you have to start with 0.2 units per kg any time of the day, but same time every day. That is the message to be conveyed. So you have to write down in your prescription the time, not before meal, after meal or bedtime. You have to write down specific time, 8 p.m., 9 p.m., 10 p.m. and you have to counsel patients that they have to take insulin same time every day when they are using this basal insulin analog. OADs can be continued and maximum dose we can go up to 0.5 to 0.6 units per kg per body day. So to summarize, I will say in type 2 diabetes, timely insulin initiation is the key, and I think basal insulin, it addresses most of the barriers which are there in timely insulin initiation, and that is the way to start insulin therapy in type 2 diabetic patients, because it is associated with lesser hypoglycemia, lesser weight gain, better treatment satisfaction, better treatment adherence as compared to premix insulin. Whether it is a premix analog or co-formulation, this has got a better advantage as far as hypoglycemia and weight gain is concerned, and Glargine 300 has got an edge over Glargine 100 by further reduction in nocturnal hypoglycemia, and that is to be preferred in most of our patients who are requiring insulin initiation in type 2 diabetes. I think I will end with the quote of Professor David Owens, that we don't start insulin early enough, and even if we start, we don't use it aggressively enough to reach the target. So we need to overcome that inertia in our clinical practice, start insulin in a timely manner, optimize it, intensify it, reach targets, and that's the way you can give your patients long life free of complications. Thank you very much.
Any questions?
Yeah, less number of patients, still not that much, but there are patients who come and they say that sugars are not controlled. Insulin. Yeah. But particularly many patients who are on premix, they come to ask for, when they hear that only one basal insulin is going on with oral drugs, they come that can we shift from this to basal insulin with oral drugs. There is an advantage. If you become member of RSSDI by 30 this end of June, you will get complimentary registration of annual meeting of RSSDI at Chennai also. So all of you who are not registered, please become member of RSSDI and avail this opportunity of getting free complimentary registration of annual meeting at Chennai. Thank you.
Thank you, Dr. Pradap.
I think that should be highest round of applause for the person behind the organization. Thank you, Dr. Pratap, both for the lecture and also for the excellent organization. Thank you.
One more thing, I think with the basal insulin which he has given the talk, one thing which we can do, one more thing which we can do, we have many patients who are on basal insulin, probably, and one real world data from RSSDI Gujarat chapter we can collect. If you see any patient who is already been started on a insulin therapy, may not be your patient or may be your patient, may be following you, may not be following you. We will make some simple protocol, can
sent to everyone and what is the status of the control. So patient who is already started on insulin, how long patient is diabetic, how long patient is started on insulin. We just want to know what is the status of control. So we will understand that intensification, even the patient who is on insulin is not done optimization in intensification. So one simple a cross-sectional study can be done, and we can have a ethical approval for all centers. So whoever who are interested in participation, they can do. We can have a good data from Gujarat. And it is nothing to, we will not be asking for your name, your hospital, patient belongs to you, patient belongs to XYZ. Is nothing, we just want to have a data which can be done, a real world data, which can be published also.
I think another point which I missed during presentation, whenever you put a patient on basal insulin, you need to counsel them that you are starting with 10 or 12 units, but their actual requirement may be up to 0.5 units, because otherwise they will keep on taking 10, 12 units and come back after 6 months and there will be no glucose.
Now we have Dr. Tejas Shah for the next lecture on treatment intensification with SGLT2 inhibitors plus DBB IV inhibitors. Dr. Tejas Shah, please.
Thank you. Thank you very much. Good afternoon to everybody. First of all, a big thank you to the entire team of Gujarat RSSDI and especially Dr. Pratap for having invited over here. It was indeed a wonderful opportunity to come here, and truly congratulations for selecting such a wonderful venue. It really showcased to the world and to us how wonderful this place is, and this statue has been made, and it's a proud moment for all of us in Gujarat and in India also. So as this is an Astra session, a thank you to Astra also for the session. As the title suggests, we are going to talk today about two important combinations, that is the SGLT2s and DPP4s, fixed dose combinations, and their place in current therapy. These two drugs have actually revolutionized the way we are treating diabetes. 10 years back, maybe on 15 years back, we were primarily glucocentric. We used to aim only at HbA1c. We used to look only at blood sugar levels and bring down the sugar levels. That was our aim when we were treating patients, whenever we were talking to our patients. But in the last 15 years, following CVOT trials, following these newer drugs, we now know that it is not only glucocentric management, but we are looking at a patient in a whole. We are looking at the cardiorenal morbidities. We are looking at the drugs which can give us benefits, do not cause hypoglycemia, do not cause weight gain, and therefore the place of these two drugs in therapy is something which is going to change the way we are managing diabetes. So the prevalence of diabetes is huge, we know that. If you look at this latest data from the India Diab study also, which is an ongoing study, what it is telling us that the incidence of diabetes in the younger age group in India is increasing. From the age group of 24 to 39 years, we are seeing the maximum growth in people with diabetes. And after the age of 65 years, the incidence of diabetes is going down. That is the prevalence that is happening nowadays. What we are also seeing is that people are getting diagnosed at a younger age, but also with the typical Asian Indian phenotypes, where we see more adiposity, we see more resistance, and also there is a beta cell failure. If you look at the data from a real world evidence study also called the Discover program, which had more than 3,000 patients, the mean HbA1c after 4 years of treatment, in spite of patients being on two drugs, sulfonylurea and metformin, the mean HbA1c remained at more than 8.5. 32 patients of this were already on metformin, 27 to 30 patients were, odd percent of the patients were on more than two drugs. But however, the A1C remained at a level of more than 8.6 or 8.7. Which brings us to the point that what do we need to do when we see or manage a patient with type 2 diabetes? Are we looking only at glycemic control? No. We want to bring down the glycemic control. We need to look at the weight management. We do need drugs which will not increase weight at all, or which are more or less weight neutral or can cause weight loss. We need to look at comorbidities along with diabetes, that is preservation as hypertension, cardiovascular disease, renal disease, etc. And choose a drug which is causing less hypoglycemia or does not have an hypoglycemic risk.
The importance is why early intensification? Why do we target our patients early? Now, if you look at the various studies right from UKPDS and DCCT, what it has taught us that we need to control our patients well from very beginning. Because if you control them well, the benefits are derived later on in life, maybe after 10 years and 15 years also. So this is a summary of one of the meta-analysis. This was done. It was a retrospective cohort study done on patients. Patients who were under treatment from 1990 to 2012 were evaluated here. More than 1 lakh patients data was collected here. And it was seen that those patients who kept an A1C of more than 7 for a period of more than 1 year, that means there was a delay in intensification of almost a year, there was an increased chances of almost 26% of rate of myocardial infarction, and any CV event increased by almost 26%. Same type of cohort patients, more than 1 lakh patients, when they kept an A1C of more than 7% for more than 2 years and a delay in intensification, it automatically increased the ratio by almost more than 1.8 times increased chances of developing a myocardial infarction. If you look at the data from ACCORD study, we always talk about ACCORD study as a study which showed a problem when we intensified blood sugar control or which increased the rate of cardiovascular event. But if you look at the data of HbA1c in ACCORD study also, those patients who were kept under the strict glycemic control of around 6 or less than 6.5, they had increased chances of reaching the target goal of HbA1c of less than 6.5 even after a few years. That means if you intensify early, if you control our patients early, very beginning, the benefits are there to see. UKPDS has taught us that there is something called metabolic legacy, there is something called legacy effect. If you control the patients well in the first 5 or 10 years of diabetes, there is automatically a chances of improving, reducing the microvascular complications by 37%. There is a reduction of myocardial infarction by 14%, and any event automatically goes down after almost 10 years of diabetes also, even if the glycemic control fails in the later on years of your life. This is the data from newly diagnosed Asian patients, where Asian Indians which were evaluated. Interestingly, this was a study where they looked at the urban population surveyed which was done, as well as patients who were attending the urban clinics in certain metro cities of India. What they found out that the A1C in the urban cities or the urban clinics was more than 9.1 compared to 8.3 in the other urban survey that was done. Number of patients with an A1C of more than 8% and more than 9% was significantly higher for those patients who are attending the urban clinics. So let me give you an example of a case study. 47-year-old male smoker and type 2 diabetic for more than 2 years, has a severe fear of hypoglycemia because he has seen an episode of hypoglycemia in the past. He's on metformin twice a day, 1000 milligrams with antihypertensives and a statin. His current parameters show an A1C of 8.6 with lipids at 107 and a GFR well maintained at around 85. So naturally, a patient on a single drug just now, but a young person, he's a smoker, his A1C is almost more than 2% the target, above the target level, even after 2 to 3 years of diagnosis. He has a fear of hypoglycemia, and most importantly, he's in a phase where he's developing a bad legacy, which might cause him a problem in the future. What are we targeting him for? Are we going to add a sulfonylurea? Are we going to add a DPP-4? Are we going to add a single drug like an SGLT2 to bring down the blood sugars? Are we thinking of an injectable for him? Or we are thinking of a combination of 2 drugs like an SGLT2 or DPP-4? If you look at his parameters, we need a reduction of almost 2% for his age, for his HbA1c, or at least more than 1.5%, which no single drug might be able to give us. He has a fear of hypoglycemia. We do not want him to gain weight. So naturally, we are not thinking of a drug like a sulfonylurea or insulin in this case. So naturally, a combination of 2 drugs, if we are thinking of an SGLT2 and a DPP-4 combination, becomes the best possible option. Now, there are 2 ways of thinking about it again. In the past, earlier time, there was a method of stepwise addition of drugs. When one drug failed, the second drug was added. When the second drug failed, the third drug was added. And that what the thinking behind it was, there was no urgency. Why should we bring the sugar faster down? It adds up to the cost. It adds up to the fear of hypoglycemia. Is it over treatment?
But now we are thinking differently. We are looking at targeting with 2 drugs more faster, because the faster you reach the target, the better it is. It just gives us more window of opportunity. It gives a position for better future. It overall reduces the lifetime exposure of high glucose over a period of time, and it requires more motivation, and we need to overcome the inertia that we are having in treatment. Let us look at the rationale behind this combination. What we need when we are treating a patient with type 2 diabetes, we need a drug which will target multiple defects in diabetes. We know that it is not now a single defect which leads to increased sugar. There are multiple pathophysiologic defects which we need to target. We need to have treatments that give glycemic as well as non-glycemic benefits. We need to reduce the occurrence of hypoglycemia or weight gain, and a treatment that overall would improve the compliance of the patient. Homogeneous octet is well known in the field of diabetes now. There are different pathophysiologic defects, and we need drugs that would target as many defects as possible. So when we are looking at a combination of SGLT2 and a DPP4, we are covering almost 6 pathophysiologic defects. SGLT2 working mainly on the kidneys and also overall slightly on the pancreas, on glucagon, while DPP4s more or less are working on different pathophysiologic defects, and therefore we are covering most of the defects when we are targeting that. Now when we are looking at this combination again, there is a unique synergistic action which we are looking at. If you look at the SGLT2s, they are mainly working on the kidneys. They cause glucosuria, they more or less decrease weight, they decrease the blood sugars, they improve the insulin sensitivity, and they have a slight effect of increasing glucagon when they start working initially. At the same time, DPP4s, they have a direct incretin effect. They cause DPP4 inhibition, prolong the action of GLP-1, and thereby causing increased insulin secretion, and also they have the negative effect on glucagon by decreasing glucagon. So these two effects, or these two drugs, more or less complement each other in a wonderful way, thereby bringing down the hyperglycemia and thereby giving the pleiotropic benefits that they give also. Apart from that, these drugs have shown us what cardiorenal benefits they are giving. SGLT2s mainly working on the kidneys, mainly improving the heart, reducing the hospitalization for heart failure, reducing the body weight, reducing serum uric acid, has effect on systolic blood pressure also, and the DPP4s more or less being weight neutral, and also has shown to be very, very safe when it comes to heart. So when you look at the combination of these two drugs and you compare it with other drugs that we are using, more or less they score well in almost all the parameters. No hypoglycemia risk, weight neutrality of DPP4 and weight loss with SGLT2, CV safety being proved with DPP4s versus the benefits that CV these drugs give, SGLT2, and per se effect on the blood pressure also. Now let us come to the rationale behind a fixed dose combination. Do you know in India we had more than 500 combinations of fixed dose combination drugs a few years back. More than 50 different combinations with 500 brand names were available. Then government started rationalizing this, looked at the rationality of combining two drugs and banned 350 or more than these combinations, out of which almost 20 to 30 were with metformin. The rationale behind this is that these two drugs should be rationalized when we combine them. Overall, the benefit of FDC is to improve the pill burden, to reduce the pill burden, to improve the glycemic control. It helps us to delay the need of insulin therapy. It improves the compliance and adherence. When you improve the compliance and adherence, studies have shown that even 10% improvement in adherence or compliance of a patient reduces the A1C by almost 0.1 to 0.2% in clinical studies. So the combination, when you use these two drugs, overall the improving adherence, improving persistence and compliance per se helps us to reduce the HbA1c. It gives us an ease of administration, ease of remembrance. There is a synergistic action happening both of them, and overall reduces the cost burden also when you are using an FTC. This is a meta-analysis that was done with a combination of an SGLT2 and DPP4. It was a meta-analysis done with almost 2082 patients. 7 clinical studies were enrolled in this. 4 of the studies used a simultaneous addition of an SGLT2 and a DPP4, and 3 of the studies used a stepwise combination. It looked at the change in fasting and postprandial blood sugars, it looked at the change in HbA1c, and it looked at parameters of safety like hypoglycemia and thus genital and urinary tract infections. What it showed was that the combination of SGLT2 and a DPP4 per se offered greater reduction in HbA1c by more than 0.3 to 0.5% as compared to even a stepwise addition or as compared to a DPP-4 placebo combination. When they looked at the sequence of hypoglycemia, there was a clear lower risk of hypoglycemia when the combination drugs were used, SGLT2 and a DPP4, as compared to sequential adding as well as compared to combination of these two separately. Importantly, there was a 49% lower incidence of genitourinary tract infections, which favors the use of SGLT2 and a DPP4 when compared to when they are using it separately. So whenever using a combination of these two, it has been seen that the genitourinary tract infection does go down clinically also. There have been some mechanisms behind it. There is found to have some inhibition of DPP4 in anaerobes happening. There is found to have a direct effect on the fungal infection. There is found to, because of the reduction of glucotoxicity also, that these fungal infection goes down. There have been different studies done with different combinations. This is the data where DAPA and Sexa was combined and compared to Sexa plus MET versus DAPA plus MET combination. And clearly the HbA1c reduction in patients with an A1c between less than 8, between 8 to 9 and more than 9 was all superior when the three drugs were used together as compared to single drug being used. This is a meta-analysis done with 58 randomized control trials with more than 31,000 patients showing the efficacy of a DPP-4 as compared to other DPP-4 where saxagliptin showed a superior reduction here. This is again the effect of Sexa-DAPA combination on the HDL levels and triglyceride level where it showed an improvement in HDL and a reduction in triglyceride when they use it as a combination therapy as compared to a monotherapy. And again here there was a reduction in the vulvovaginitis, balanitis and genital tract infections in the combination arm when all the three drugs were used together as compared to two drugs being used together. Similar, now we know clearly that individually these drugs have given us a lot of benefit. DAPA in DAPA-HF and DAPA in DECLARE has shown a reduction of 17% in relative risk in myocarditis in the CV event also. There is clear benefit in terms of heart failure hospitalization. All SGLT2 inhibitors have shown us that they reduce the progression of renal disease over a period of time. In patients with established CKD also, there is shown to have benefit that has been seen. In DAPA-HF, what we know that in patients with diabetes versus without diabetes also, there is a 26% relative risk reduction in terms of CV death or worsening heart failure. Different mechanisms and not only on reduction of blood sugars, and when we use these in combinations, overall they are giving us the benefit much more. Similar benefits seen in combination of EMPA and LINA fixed dose combination. This is a study where they looked at the combination of FDC of EMPA LINA and compared it to sequential adding of empagliflozin and linagliptin separately. An HbA1c reduction of almost 1.19% in the combination arm versus 0.62 and 1.84 in patients with an A1c of above 9%. Even in patients with drug-naive patients as well as on patients on metformin background, more patients were likely to attain the desired HbA1c target of less than 7 when they use a fixed dose combination of this. Finally, are we concerned about the heart failure risk when we are using a combination of a DPP-4 with this? Because there was some concern related to saxagliptin in the past that it causes an increased rate association of heart failure, because in SAVOR TV there was a 27% increased risk of heart failure hospitalization seen. When you dissect the trial slightly more closely, and if you see at the graph at the hazard ratio which is seen over a period of time, the maximum the hazard ratio is around 1.8 in the first 6 months of therapy. It goes down to 1.46 at the end of 1 year and goes down to 1.27 at the end of 2 years time. And it was hypothesized that if the trial would have extended for some more period, the hazard ratio would have gone down to almost 0. So whether the numbers were counted more early, whether the patients that were enrolled in the study were different, is what has been the theory. Rehospitalization after initial heart failure was similar between the two groups. There was no difference in weight gain. There was more cases seen only in patients with an increased pro-BNP, and therefore that issue is now somewhat dying down when we are talking about heart failure and DPP-4. There were some small studies done later on also, the MEASURE-HF study which looked at the left ventricular end diastolic volume effect with saxagliptin, and clearly did not demonstrate any cardiac structural or biomarker changes which were indicative of worsening heart failure or in patients with type 2 diabetes. Looking at the guidelines, clearly all the guidelines have now recommended this combination to be used first, SGLT2s as the first line of drug for patients on metformin or uncontrolled on metformin, or even if the patient has cardiovascular risk or renal risk, then you can use this drug even before metformin is what the clinical study guidelines have now clearly said. 2022 ADA, which has happened just last week, also endorses these guidelines again this year, and which clearly tells us that for any patient with a high CV risk or heart failure risk, the SGLT2 with proven benefit is the drug of choice, and more or less these drugs should be used early in the treatment. So to summarize, the combination of an SGLT2 and DPP4 is something which is well fitting for Indian type 2 diabetic patients, especially the Asian Indian phenotype. These combinations offer a synergy in glycemic control. Along with the glycemic control, the SGLT2s and DPP4s have better cardiorenal outcomes. Combination provides a better reduction in incidence of genital tract infections and hypoglycemia risk, along with significant weight loss and potential primarily to delay the disease progression and overcome the clinical inertia when we start early in management. Thank you.
Any questions? I would request Dr. Chindan to give the moment to Dr. Tejas Shah, please. Sanjay Agrawal from Pune. The topic is options for intensification after basal insulin initiations in type 2 diabetes.
Sanjay is the National Secretary of RSSDA, an eminent physician and diabetologist, director at Jangir Hospital, Pune, and he is the last speaker. So he started.
Correct choice of insulin that we need to start the patient with, and how we're going to titrate the insulin therapy to get patients to better glycemic goals.
This is going to be the overview of that talk, where we're going to talk about the need for insulin intensification, how do we go about it, the art and science of the intensification approach, and what are the practicalities in step-by-step approach. And what Dr. Gandhan is giving some evidence-based recommendations. We know that patients with type 2 diabetes have early loss of first stage of insulin secretion, resulting in postpartum hyperglycemia. And obviously, postpartum glycemia, when you look at the overall perspective of the A1C elevation, it contributes a lot to the glycemic exposure. So what is the significance of postpartum insulin consumption? We know that attempts to reach target A1C range eventually fail if postpartum glycemia is uncontrolled. We know that postpartum hyperglycemia generates oxidative stress, leading to endothelial dysfunction and inflammation. And there is clinical and epidemiological evidence that postpartum glycemia is a marker for cardiovascular risk. So obviously, So these are the patients who will be ideal candidates to receive a full basal bolus therapy. And in the new study, they looked at largely the utilizing premix. And these were patients with type 2 with an A1C of more than 80 to 7%. And they were compared at they were followed up for 3 months, 6 months, and then 9 months. And they were looking at how many patients achieved A1C reduction from the baseline and the hypoglycemia event rates. What it did conclude was that the basal bolus with superior glycemic control, with superior basal bolus to premix insulin without an increase in the rates of hypoglycemia. So this is a very important conclusion because when you intensify therapy suggests that timely basal intensification is critical to sustain glycemic control and mitigating adverse metabolic legacy effects. Addition of tandem basal insulin is a more physiological and patient-friendly approach, and basal plus median effective alternative to premix intensification approach, especially in terms of better safety and flexibility. Friends, the ultimate message that I want to give you is bring a patient to target goals, simplify your treatment algorithms, do not make it complex. You visualize the goals that you want to achieve, and you should achieve this with the best possible safety, avoiding hypoglycemia and weight gain. Individual patient to decide the approach. So don't be very dogmatic in the way we approach our patients. We need to teach them how to sort of self-isolate because it empowers the patient to be better, there is better adherence to the therapy, and eventually the patient comes back with better readings to you. Thank you very much for your patience, sir. Thank you all.
So now we can close. We don't have any question. For closing ceremony, we would like to have our chairperson and chair-elect, both from RSSDI, to come here, where the secretary. And before their closing remark, we have with us Dr. J.K. Sharma from RSSDI National Executive Committee and Amit also from that National Executive Committee for their comments for RSSDI Gujarat chapter meeting, and then we will have with others. Yes, over to Chair.
Thank you very much. Go ahead then.
Thank you, Dr. Bansi. I represent the National RSSDI and I have worked under the chairman in the presidency of Dr. Bansi Sabu. And I am extremely thankful and very happy to see here that the Gujarat chapter of RSSDI is working so hard, and it should be the role or the model branch or model state chapter of RSSDI, because I have come to know that there are 25 states as on today and there are going to be 38 very soon, and this meeting is being represented from all over the Gujarat, not only Gujarat but from, we can say, all over India, because this faculty has come from all over. And I have seen and I have observed the workmanship, the leadership, the vision, the mission of our past president national of RSSDI, Dr. Bansi Sabu. And I appreciate and I thank to Dr. Orman Dhruv, the present chairman, the chairman-elect, Dr. Pratap Jethwani, and also Dr. Desai, who is the secretary at the present time, and the involvement of every person from all over Gujarat, not only one place, from all over Gujarat. So this I am talking on behalf of RSSDI National as the EC member, because they have deputed me to be an observer of this particular meeting, what is being done, and this will be replicated in all state chapter meetings. I am the I am the chairman-elect of RSSDI Delhi chapter. I have worked as secretary for 4 years, and we have not been able to do to that extent. The coming president, Dr. Bansi Saab, Dr. B.M. Akkad is from Delhi. So I am really very, very happy, and I congratulate everyone. I thank from the core of my heart for whatever has been done, the best topics, the best faculties, best speakers, and a good involvement of all the people from Gujarat and outside. So thank you very much, and I express my thanks to everyone. Thank you very much. Best audience, that is what I have said, the best audience. Thank you, sir.
Thank you very much, sir. Thanks for these good remarks. Just the validatory function, concluding remarks from my side. We are very much thankful to all the national faculties, Dr. Vasant Kumar and Dr. Our Vice President, also our representative of the RSSDI committee, organizing committee from the national board, and Dr. Bansi Sabu. But the most important people whom we should thank is the audience, the people, the delegates who attended the conference, because there was not a single session where there were not questions, and that gives us more satisfaction than the lecture itself. So the lectures from the dignitaries all across the national faculties were wonderful, but the participation from the delegates was equally good. The participation suggested not only the inquisitiveness, but also suggested their their knowledge also, because most of them were very knowledgeable. So we are very much thankful for the participation that you have done during this conference, because at the beginning of the conference we were little skeptical about the presence, but most of the halls were attended fully, and that's really the biggest achievement of the conference. All the compliments for the achievement of the conference go to both these people, one on my right and one on my left, Dr. Jetwani and Dr. Desai, because without them this would not have happened, and they did practically everything that was possible, starting from the scientific agenda to the putting everything onto the placement, collecting the funds and making these arrangements. Of course, RX events has always been very disciplinary and very organized place for us to lean on to whenever we need such conferences. So once again, thanks to Dr. Hardik and Neelam, and thanks everybody, especially the sponsors. Thank you very much.
Thank you very much, all of you, for your active participation. And we will be meeting next year, I think in the third weekend of April. Place we will just release for our next annual meeting. And we all encourage you to become RSSDI member if you are not member, and if you are a member, go on to website and update your credentials, because that is what is required. In upcoming elections, you will not be able to vote if your credentials are not correct. So do that. Encourage more people in your vicinity, your friends, your local associations to become RSSDI member. And I already told you that if they become member by the end of this June, they will get that complimentary free registration for annual meeting of RSSDI at Chennai also. And it's only 6,000 rupees for lifetime membership. And anybody who is MBBS can become member of RSSDI. It is not MD medicine. MBBS plus any only MBBS, they can become member of RSSDI. I will hand over to Sandeep.
Thank you all. So I really thank Dr. Pratap Jetwani, Dr. Uman Dhruv, Bansi Sabu. Actually, I'm at this stage because of all these people who has promoted me here. And really it was a good event. In the last session also, in the B hall also, there were a lot of people listening. So probably almost like national conference the audience was. And thank you everyone for attending it. And thank you Bansi Bhai for giving me this treasure.
Force, and because of that we all are here, and I think he will be there to guide us in future also.
Now you made me patron, so there is no need for me to be there. But one very important thing that we started our RSSDI Gujarat chapter, one of the first early-most chapter in India, and probably with most disciplined way it is working since last 15 years, almost 2007, and submitting our accounts, sending our accounts nationally every time, regularly doing once in a year meeting, doing executive committee meeting, doing AGM, doing elections. So everything which we have done, whatever is written in our constitution, and definitely would like to have from next year onward also, all these things should continuously, we should update our RSSDI state chapter, as well as all our activities should be updated at national level. One very important thing from the Dr. Devang, which I would like to say, that we should also update RSSDI newsletter with our RSSDI Gujarat chapter activities. So whatever the activities which we are doing in Gujarat, they should reflect at national level on our website, on our newsletter also on regular basis. Thank you.
Sir, I would just like to say one thing. Gujarat is known for leading the country and giving leaders to the country. We are in the land of Gandhi. Now, yesterday we visited Statue of Unity, Sardar Patel. Our Prime Minister is also from Gujarat, and one of the biggest leader of diabetes is from Gujarat, Dr. Bansi Sabu, sir. So, I would just like to say that, and we are. This was a really wonderful conference. Thank you.
Anyone from audience want to say any remarks or comments?
One thing, last Jaipur conference we saw that every state chapter had a stall.
Yes, it will be there again in Chennai.
So we saw that many chapters stalls were meant, but Gujarat chapter there is nobody and no reflection.
So this time we will take care of that. So this time again in Chennai we will have the village. It is all state chapter they have to represent there, and in Chennai also we will represent in a big way. That is what I can say. Yes, sorry.
Thank you.
We will do it.
Thank you everyone for joining, and now we conclude our event here and we will depart for lunch. Thank you.